Okay, Julia.
Great, thanks. I have to hit continue, I believe. Okay. Hi, good morning, everybody. I'm Julia Meno, and I'll be teaching neuro strategies today. I believe that everybody has watched a previous course neuro on aquatic therapy for spasticity and contractures prior to coming into this room. Am I correct? Yes? I need a nod from somebody.
Yes. Yes.
Yeah, so yeah, that's fine. You can put your microphone on. So you've watched that, and does anybody have any questions from viewing that previous presentation? And I'm going to try not, I am going to, I don't think this course is going to overlap. I think there's one video in here that might be in the previous course that you viewed, but the information, I tried to keep it separate. So I'm going to move into, and certainly if anybody has a question, with this small of a group, looks like there's 8 people. Yeah. And feel free just to click your microphone on and say something, because sometimes I don't always catch the chat. Like somebody just put a chat. Okay, and I see I think
That's just me, Julia.
that's you. Okay, sorry about that. Let me go back. Okay, um, I also sent out a handout ahead of time, and I'm going to share the screen right now so that you're not confused. There's a keynote presentation which I sent ahead of time, so you should have a PDF of that. And then I shared also a handout that says Aquatic Neuro Strategy course notes. Now these course notes were designed for what I do in the pool. And I'm going to refer to this because they're a little bit more detailed. You'll see some of it in the video, and then I'll refer back to the course notes specifically when you see the information on sit to stand and seated weight shifting and pre-weight bearing, those type of things. All right, I just want to be clear that what you have on your computer. So let me switch back to the PowerPoint. Oop, let me not do that. Screen share. Dun, dun, dun. Okay. I'm sorry, I'm trying to figure out how to shorten the box so I don't have everybody is on my screen at the same time. Okay. Go down. Okay. I'm looking at specific neuro considerations for working with clients in the pool that have either central nervous system or peripheral nervous system impairment. And I like to have the clients come to the pool ahead of time to take a tour of the facility and look at the assistive equipment. I have a quick question, Monica. I'm trying to shorten I have a hard time reading my PowerPoint because I see all the images on the right. How do I make that smaller?
Go to view, and you could do standard view or just with speaker. Oh, wait,
Here we go. Hold on.
are you talking in your PowerPoint?
I got it.
Okay.
Yeah. Yep. There we go. Put that off to the side. Thanks. That was distracting. It's like saying too many things. I also have a quick question to the group before I keep going on here, because I wanted to know what type of clients that you're seeing there in Allentown. Are you working with a lot of stroke patients, or spinal cord patients or Guillain-Barré, I wanted to get a little feedback, and if we have a lot of experienced therapists here, that will dictate a little bit how I roll through this PowerPoint. So anybody that wants to chime in and give me just a brief who works at there, what type of clientele that you, if you're seeing everybody and if you have got a lot of experience. Nobody. Okay, well, I'll keep going.
Can you hear me?
Yes, I can hear you now.
My name's Linda. I work at Good Shepherd, and we have spinal cord injury patients. We have stroke patients. There's a number of we have all different types of patients that we see.
Okay, and do you have a set up a program just for your neuro, or do you see them one-on-one, or do you have do you graduate them into small groups? Do you have just inpatient and then also outpatient, and do you have do they go then into a community program?
We have mostly outpatient physical therapy, and then they can transition into the fitness and wellness program. Usually, depending on their skills, physical therapy will see them one-on-one in the water with them, depending how they are. And then when they transition to the fitness program, again, depending how they are, they can see the recreational therapist in the pool one-on-one, or transition to some of the group programs, again, depending on their skills.
Right. Okay, terrific. Thank you for your input. I appreciate it. Well, when I have, so I'm going to roll through some of these fairly quickly at the very beginning, because I do have a little over an hour, I think, of video that I want to make sure that we get to watch and questions answered. I do have people come ahead of time to tour the facility. That could be part of your initial, land assessment, where they come look at the facility, see what some of the challenges might be, look at the locker room. And it also enables whomever is accompanying that person, if they have mobility issues or cognitive issues, to know what lays ahead, what's in store, so that your program can stay on time and that you have the right kind of equipment prepared for that person. And a lot of it's for their own safety, and also the safety of the person that's coming with them, to help them navigate the locker rooms, the showers, the ramps, the doors, all the way out to the pool deck, and even to experience coming into the natatorium where the pool is, the sights, the sounds, the smell, all of that can affect your client. And I noticed it's much more so with people with a neurologic condition. And then also looking at your water entry coming into the pool with somebody who might have sensory deficits, whether it's visual or tactile. The water entry is a key component to their safety. And some people will need to use the lift when you come in, and make sure that you stabilize that person on the lift. Some people might need 2 or 3 people stand by. Other people can just do it with one person. If at all possible, having the person enter into the pool with a 0 entry and be able to come in either just walking with a walker, a PVC walker, or just a hands-on assist, or a cane. And the most independent that they can enter safely is the way to start. I like to know the individual's VO2 capacity, if they've had a head injury or upper spinal cord injury. That is, and even people that have other conditions that affect COPD, because that vital capacity is also going to impact their experience in the water. You want to know ahead of time, so you're setting them up for a successful program. And doing thoracic expansion and assisted intercostal mobilizations and some lymphatic type work in the pool might be part of having them come into the program of coming into the water. If their vital capacity is very low, it could be a contraindication or certainly a precaution. And you'd want to have that person starting out in the supine position and slowly then submersing the thorax or bringing them down or up into the vertical position. Primitive reflexes, to know if how their primitive reflexes are, if they intact, do they have primitive reflexes? Have they gone back? Have they lost some of their developmental reflexes and have gone back, or if they've never developed the reflexes fully? That is also important to know, because you'll want to set up your program and positioning and your tactile cues based on that. And certainly communication skills and a communication aid there at the pool or at the beginning, either having a communication board. I use laminated cards. You probably have some of these things already at your facility. I also use a sign language for like putting your face back in the water, relax, face back, kicking there. And I've laminated a few ones for using the restroom, for things being uncomfortable, where to move in the pool, so that if you need to point at the card, that's great. Some of them are up on the wall next to the pool so that I can look at them and remember. And if you cannot communicate with the person, you can't really have you can't really have a program that's going to be very functional for them. It'll be more of maintenance and for joints and soft tissue and for interstitial movement of fluids in their body. I like always to have a family member or somebody that works with that person on a regular basis. OT aides frequently come and assist people in the locker rooms and use that time for working on ADLs and assisting with bringing them out to the pool and helping me at the beginning understand facial expressions or what they mean by certain gestures if they aren't verbally communicative. Certainly knowing the level of impairment. Bowel and bladder continence is a must know. And if you can get them in the pool on the right, if they're on a B&B program, knowing what the best time of the day to come in for that individual is going to be beneficial, and also using a containment brief. I have one here, I'll show you. I've got two. I'm digging down, sorry. Thanks. I have two types here. This one is very effective for somebody who cannot step into it. It's got Velcro on both sides like this, so that it's easy to put on, and it's lined. I don't know if you can see it, but it's lined with a nice like a pile, a very thin micro pile. And this works terrific. This one's made by Discovery Trekking, and it can fit all different shapes, which is nice. Sprint makes one. A lot of companies do. Kiefer. Here's the old standard one. This one is an adult medium, I believe. And if I was at the pool, I could, I would take a whole glass of water and pour it into these, and it does hold it. It really does. And so it does really good for liquid and solids. So having one of those, if you work with people that are on the Medicaid waiver, oftentimes they can be provided as with an equipment justification because it helps them participate independently, or in not so much independently, but in an aquatic program in their therapy, and will give them independence when they move into a community-based program. And I like to know the individual's coping strategies. If they get very frustrated easily, do they get angry? Do they, how do they problem solve? Are they willing to slow down and practice? And and that goes also into their emotional state. So these were just nice specifics that I focus on for neuro as opposed to an ortho client. Moving along here. So I put in environmental concerns briefly because it does go in hand with individuals who may have sensory issues of sensory processing. One would be for your clients if they, I put down here the changing room. Certainly the marking the stairs and the different depths and making it very clear to individuals, even though it might be obvious to you as a therapist that that everything is marked correctly, pointing it out to these clients makes a big difference. Actually bringing your hand down the handrail as you enter the pool and going underwater, out of the water, underwater, even on the railings, and showing them the right where the marked depths are. And that might be when you're sitting on a stair, literally tapping that marked stair. The railing, I have them slide their hands up and down the railing, or certainly they watch my hands, then I put their hand, if they can, slide it on the railing. So they have a tactile sense. They've got a sense of proprioception in space where they are and how they can use the railing, not just for ambulation or stabilization, but also that it's a visual. When you have refraction of the light as it goes through the water, for people who have not been in the water for a long time, or if they have an acquired neurologic condition, sometimes that visual cue is very distorted. And they might think of the object coming into the water and breaking off at a 45-degree angle. And that includes, sometimes they'll look at my legs and get very disturbed because they see my legs look like they're off on an askew when they hit that refraction. Or you may have encountered this working with a client and you're doing arm positionings in the water, bringing the arm across the midline or up to the surface and into midline and out. And they might get very concerned because they think, they're like, I'm not moving my arm. So they'll think my arm is their arm or vice versa. And in the mind, it gets very confusing. So taking a moment to explain, for some people, the explanation helps. Other people really need that tactile sense of, I'll stroke down their limb in the water so that they give a sense where that limb is, and stroking down the skin, and especially on a spiral diagonal into the midline as you go down the skin on their body, helps them relax. It's very relaxing to be stroked down the skin as opposed to stroking up. If you want to alert somebody, stroke up their back, just a nice little hand up the back, and that gets them alert. Stroking down the lateral grooves of the spine with a soft hand relaxes the body, but certainly doing that down the limb of the arm when the person's in the water, just to help them have a sense of where they are in the pool, underwater, in the water. My arms are in front of me. My arm is separate from your arm. It gives a lot of feedback. And the water and air temperature, it's important for it to be fairly close together. You don't want to have all of this nice relaxing mobilization in the water and then hit that cooler air temperature and have vasoconstriction, and then have the individual experience untoneward effects, meaning the body becoming rigid again and more increased spasticity. So the water temperature, air temperature, if they can be fairly together. If you have a hydroculator in one of the rooms, or a sauna, or some means to heat up towels, that it makes a big difference with neuro patients. I'll have heated towels, so when they're coming out of the water, they immediately get wrapped in a nice warm towel. Having a bright color like orange or yellow makes a, and also is very cheery, keeps them uplifted, and makes you feel better. It's a lot better than being just put into a white towel or even a brown towel, but having a nice bright color. The time in the water I keep at a, if a person has a high level of pain, that let's say they're having severe nerve pain in their spine, the time in the water might only be 12 to 15 minutes. So you don't have to stick with a dedicated full hour, or however their allotted time. You have to look at where they are and what their pain level is. Water depths used are important. Lighting is a big thing. When neuro clients, if they have perceptual issues, standing and working in the pool, you do not want to have a big window behind you. So if I am in front of a big window, it makes me look like a dark outline. They cannot see the movement of my legs and body. You need to be able to have them stand with their back to the bright light or the window, and so they can see down through the water. So pick a point in the pool where you know they're not getting a lot of refraction, bouncing reflection. I mean, bouncing light off of the surface of the water. That's very important. Excuse me. And also, fluorescent lights above the pool can cause rippling, and it looks like little wiggling lines on the surface when there's waves. And that's very disruptive for somebody with a perceptual issue as well. So pick a good visual area in the pool to work with the neuro clients, especially if they've had any kind of sensory perceptual issues. And sound is an obvious one of keeping that startle reflex under control, or if somebody has a neuro condition and a lot of pain, not going in when there's a lot of activity going on in the pool. High pain level, low sound. And as you want somebody to become more alert, increase the sounds. This is for types of sensory deficits. I'm sorry, I'm not going to lean over. So we have individuals that might have sensory modulation issues, and that is just being able to efficiently regulate the degree of responsiveness to various stimuli. Somebody might be overreactive and get very hyperreactive to stimuli as you introduce it in the pool, or just the aquatic environment on a whole. Or there's individuals typically that if they're having underreactive, these people need a little bit more sensory input. They need a little more stimulation, a more activity, a more sensation and input in order to be able to function. And there's also combinations of that for sensory modulation disorder, depending, sometimes it depends on the environment. In the aquatic environment, it's new for a lot of people. So you might see a mixed bag at the beginning. Then there's sensory discrimination disorder, and that's having individuals that are having, they're not quite sure what to do, or sequencing the desired movements and executing those movements in a well coordinated, timed manner. So that you would see this with individuals learning and doing new motor learning. They're trying to learn a new task with gait training, with manipulating equipment and feeling that equipment and having a sense of how to use it. So these, as you can't just give somebody a piece of equipment. You have to spend extra time putting their hands on, guiding them through some of the movements with the equipment, pushing it under the water with them, holding a ball with them on their hands so they can feel how much pressure they need in the water to hold on to the ball so that the buoyancy just doesn't pop it up out of the water. Anytime you introduce equipment and many individuals that have neurologic conditions, their sensory processing is going to be askewed or mistimed. And there are different types of, as you see here, different types of processing deficits. And then there's sensory-based motor disorder. And this is for people having the capacity to regulate and organize the degree of the response, the intensity and the nature of how to respond to sensory stimuli. It is how their motor challenges are when they're given, when the sensory input comes in, and how they're going to respond, what's the motor response. So that is, they're getting the input, but their response is not on mark. And that can display with a constellation of reactions, sometimes increased muscular tone. Sometimes people get very stressed out, or they either shut down or they can get hyper alert. So I just wanted to bring your attention to the sensory processing. And when you introducing of all new motor learning, you're going to take extra time depending on where somebody falls on how they're interpreting or reacting to the equipment or the environment or your instruction or the sensation of the water, perturbance in the water. So treatment guidelines. And these, I'm not even going to really go over too much because, these I touched on: minimal duration in the water to start, and then gradually increase as the time in the water as the patient improves. I'm going to share with you during the break an appendix where I've broken down level 1, 2, 3, and 4 as far as how to progress with people that have pain and neurologic or neuromuscular conditions. And as we see, it's much more difficult for somebody that has a neurologic condition as opposed to an able-bodied person because of the asymmetry in their body will distort balance. And it's much more difficult to achieve a static balance when they get in the water. Water is very destabilizing. We forget that. We get in the water and we don't realize if you're getting in the water all the time as a therapist, or you've got a strong background of going in the water, but if you've had an injury and assault to your body and your muscle tone is different, You're not able to have the reaction time that you're seeking. You cannot move your extremities in a coordinated manner, or the timing of your movement in order to have a stable stance in the water. That's it gets very disconcerting for a lot of people. Then you add on conditions that affect respiration, communication, their comprehension of what they are to do, affects their and the inability to gain voluntary control and or achieve normal growth patterns. And these all elicit a sense of fear. And if somebody is fearful or apprehensive, what do? We tighten our body, tend to hold ourselves really close in, which does not help with stabilization in the water. Our breathing gets very shallow, and we're not expanding our lungs, which helps us with the buoyancy to feel that up and down movement and to expand out for stabilization in the water. There are several components, and if you've studied a little bit of the Halowick technique, I use that in conjunction with other techniques all the time. That's running in the background. And the adjustment to water is the very beginning of what the Halowick program is about. But it's imperative to use this with all of our clients. For somebody to get mentally adjusted in the water, they have to go through several levels of adjustment. One is relaxation, how just to be able to relax in the water and when you relax, you float. And if you're not relaxed, that your extremities that you even have difficulty with, if they've got if they're denser tissue or contracted, they're going to sink. But in order to be able to have control of the rotation in the water, you must relax in order to be able to move anything that you do have control over, get voluntary control over, to gain stabilization. So relaxation leads to breath control. Breath control leads to head control. By blowing out brings the head forward in the water. Inhaling brings the head back up. So just working on breathing in a seated position or with the back against the wall, exhaling out, coming off of the wall, inhaling in, coming back, putting back against the wall, just so you can start getting this head control. And you're only in this very small sway position. And head control, your head is the great steering wheel in the water. Wherever the head goes in the water, your body's going to follow. So I do a lot of head writing in the water, and then I also do body writing, because all of this affects your core control, and which then gives you balance control. When you start getting balance control, bringing the head forward, bringing the head back, side to side, then the individual will start attaining where their body is in relation with the buoyancy. Because buoyancy, as I mentioned, is very disruptive for somebody with an altered body shape. And once a person's feeling very, has this relaxation, a little bit of sense of control, because all anybody wants is control of their own body. That's what I'm trying to show these individuals in the water, is to help them gain motor control. And then it leads to communication. Once you get the relaxation, head control, breath control, it leads up to greater communication and being able to then do more activities in the water. Now, the aquatic treatment objectives, just being in the water is the warm water elicits decrease in spasticity, inflammation due to the hydrostatic pressure, pain is reduced with endorphins and enkephalins, and there's a few other hormones that are produced that help reduce pain. And You know all of this, I believe, if you're already working in the water. And I'm going to move right along here. I definitely work on posture and frequent cueing, because posture in the water, that's a great place because people are not afraid to make these small adjustments in the water, which then lead to big adjustments on land, because they can practice it in the water. They can see what happens when they retract the shoulder blades, and they can see what happens if they squeeze their glutes. And they can start working on these small features that then will help them stabilize, so you can work on ADLs. And ADLs are always brought into the water so that people can do repetition and practice. You can break the movement components down and work on the sequencing. And you want these everything to be functional, so it has a good carryover onto land-based activities. I do a lot of sit to stand in the water, weight shifting, standing and getting the center of gravity, balance of support into the midline and out of the midline. During every time I have somebody in the water, work on pacing. People want to try to push themselves too hard. And I have to say, no, let's slow down, go for the quality movements as opposed to quantity. As they get the quality, then you can work on doing the strengthening and the endurance. Ideally, if somebody has this neurological condition and it's something that they're living with for their entire life, I want them to get recreation. If this is an environment where it is the great equalizer, they can move in the water, they can have exercise in the water, they can recreate and join some of these community-based programs. That's my ultimate goal. With the Neuro Aquatic plan, always functional goals, physical endurance goals, motor planning and coordination goals. That's where a lot of the repetition and doing it in a variety of different positions during different exercises, and then working on cognitive goals, speech, and social goals. Cognitive goals are very take time. Without cognition, individuals might not be able to assert some of the stabilization that's necessary in the reactive times. Speech is really fun to work in the water because you can blow bubbles, you can make sounds, you can, by pursing the lips, blowing out. I'll use whistles sometimes, I'll use bubbles, blowing in the water. It all helps with vital capacity, expiratory reserve volumes, and blowing. Blowing brings the head forward. It's a prerequisite. You cannot blow out if your head is back here. It's very hard to be able to blow out. The head comes forward. If you try to retract your head, you won't be able to blow out. And I work with that from going from in supine, coming into the half seated position, exhaling, breathing in, going back, all core contraction, flexion. And social goals is very good to incorporate for lifelong plans. So being PTs, you guys are already very familiar with the use it or lose it. Yeah, keep using the movement, because if you're not using it, we lose those synapses. Use it and improve it. Specificity matters, making it something specific and salient. Repetition, 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 repetition in various positions, trying to reconnect the pathways. The intensity of the exercise matters. timing when you're going to introduce that next exercise. It might, you want to have the right timing when they've laid down the groundwork. Saliency, meaning it's meaningful to that particular individual and it's something they can use. And age does make a difference. Younger minds are more plastic than the aged, and that you have transference of that of the exercise that you're doing into other movement strategies. You can transfer it to land, and mindful of interference, things that can interfere. It could be an exteroreceptive interference. It could be interoreceptive, a sensation that the individual is feeling inside of their body. Neuroplasticity and neurogenesis, it does take a long time, but as we now know, especially over the last decade, it is very attainable. There's a lot of great programs out there. You know what? I need to use the restroom, if you don't mind. I'm going to take a really quick, like a 2-minute break. Okay. Like I said, at the break, I'm going to send you a separate form with that has the levels one after another. But this is what they are. Level 1 is somebody that has instability and elevated pain levels. So everything starts out very controlled. I find a pain-free neutral position, whatever it is on that specific person, and then focus on static stability. Their back could be against the wall. They could be on a stair. They could be holding onto equipment. They're usually right against the wall being supported, or arm to arm with the therapist. There's a lot of verbal cueing, a lot of tactile cueing here. Breathing and holding postural alignment with changes to their arm and leg positions. And range of motion is typically less than 30 degrees. Repetition, see how small it is? 2 to 5. And we start low so that it is quality and keeping their pain level down. The movements are streamlined. There's no equipment to push underwater, or paddles, or any long levers. And the exercises are very much isometric holding, some pulsing, a little bit of the introduction to hold and relax. And we use hold and relax at the beginning, especially if to help with reducing spasms and relaxation. Hold, relax, hold, relax. Movements are sitting, standing, walking, and also do techniques to reduce guarding behaviors, things of relaxing movements of the body around a joint. It could be doing figure eights, might be, if the person can go in the supine, might be gentle snaking. It could just be floating, little undulations, could be rocking from the core. Very small, deliberate movements just to help with the pain. And the duration of the session is limited. I think now we're going to pop into some videos here. So use vertical decompression is something that comes right, if somebody comes in and they've got a lot of nerve pain, tight muscles in their back, in their hips, and the legs. Vertical decompression here, I've got on the left side, it looks like she's standing on the pool bottom, but she's not. She's actually, this woman's about 6 feet tall, and her feet are off the bottom just because of the noodle underneath her arms. They're about 1 inch or 2 off the bottom of the pool, so she's not touching the bottom. It is decompression of soft tissue and nerve roots on the spine and the joint. So it's doing traction without adding weights. The hands are on the wall, so they're, or on the bar, so they've got good stability. And you have the individual, they turn, so if their hands are on the wall, I'm gonna move back so you can see my arms a little bit. Their hands stay on the wall, so they're disassociating the rib cage, and the scapula is moving on the rib cage as opposed to doing any kind of twisting. The nose, the nose, the belly button, and the toes all go in the same alignment, back and forth. So the bottom side is not twisting and the head's going, they're not going opposite directions. The whole body's moving as a whole. And at the beginning, I might stand behind the individual and assist everything turning one direction and then the other. And it allows them, their whole spine is in alignment when they're doing this activity. They're not rotating their neck. Everything's moving as one. It's a gentle stretch for the thorax, the scapular musculature, and the client is in control here. So I go hands off. Most people love this. And I'm putting water noodles underneath each arm as opposed to around the person, as opposed to having a belt. Now, if somebody had very unstable shoulders, I might do this with a belt, but or I would use less flotation equipment. But this is nice and stable. It's not really pushing up because they've got their hands stabilized on the wall, where they're not free floating and having the shoulders popping up. The picture on the far right, she is now in a seated position, and she's in the corner and just letting her body sink down. And this is really nice in that it just lengthens it's a vertical traction. And now she's got some flexion. Some people that they don't like the straight lined position. And if that is still too painful, then I will put them into the seated position at the wall. I also use the corner of the wall during the beginning stages for helping people do work on balance, static balance. They will not have the water noodle. They'll just stand in the corner of the wall. At first, they can have their arms out with their hands like she has, and they're standing there, and they have a wide basis stance if they have a wide basis stance for support, and they can slowly narrow the base of support, bringing the legs closer together. And once they're about shoulder width apart, I can have them bring their arms into the center, and they're changing the lever and just standing there and trying to stabilize. If they need to make the legs wider apart, they can. As they practice this each time, they can then work on turning the head from side to side, because they're in the corner, so they're not afraid of falling. If they start to tip, they've got either side of that corner of the pool. It's a great way to use use a pool corner. This is also a nice position for doing aqua stretch if you've been introduced to aqua stretch. So use the corner of the wall for bringing the wide basis support more narrow, and working on bringing the arms into midline, and then turning position of the head, and then even doing one leg stances over time. And then here's this is a nice sacral nerve root decompression. And you put the noodle, I thread it underneath the knee, like so. So the individual can learn how to do this on their own. Their back is against the wall. They thread the noodle, meaning just underneath the knee, and pulling it through, so that it's easy. It's not a big maneuver. A lot of people try to do big thing in the water and they lose their balance, and just that movement can set off nerve pain in the spine. It's a very controlled pushing the noodle down, sliding it underneath the leg. And what the individual does is as they just breathe out, each time they exhale, surrender the weight of their leg and surrender their body more and more. And over time, that noodle's going to come slowly up and up and up towards the surface of the water, and giving a nice stretch at that of the sacrum and at the piriformis. I have people that love this. Once they learn it, they'll go do it on their own at the pool just to get this type of relief. And typically I have them hold it for 2 minutes. During that 2 minutes, the leg might be wiped down by the pool bottom, but then it has come up with each breath. I tell them surrender. If they can sink down into the pool, the standing leg is out from the wall, so there is a very slight flexion. They're not in hyperextension. And hopefully you're doing this one already, just intuitively, but it's very nice. I do stable stance at T8, T11 water depth, and using neutral pelvic stabilizations, body alignment, postural awareness. And I want I like to show tactily on an individual their transverse abdominis and erectus abdominis. And I'll have them palpate on the inside of the ilium, so they can feel it activate. And if you're working on land, I'm sure you're doing this with your clients, but I want them to unlock the knees, and I practice postural cues, weight shifting, first with the wide stance, and upper extremity exercises, assisted and resisted, to activate core stabilizers. So I'm going to have you stand up. If you're at home. And I have them find the inside of the ilium. They come onto the inside anterior portion and put their fingers there, wide stance. And if you weight shift one side to the other without hiking, without doing this, just shifting weight, you should be able to feel it activate one side and then the other. When you're in the water and you've got buoyancy and you're at the T8, you can really feel this. Here we have got a lot of gravity pushing down, but in the water it's very apparent. So I have them feel it. I'll actually put my hands there first, then I'll bring their fingertips to the spot and let them feel it. So once they know what it feels like, they can then continue to work on it at home, in their bed, in a chair. And water is very destabilizing. So you don't want somebody making quick adjustments in the water because they feel off balance. Don't set them up for that, especially if they've got this pain. If they've got pain, nerve pain, it doesn't take much to set it off. So all of these little micro perturbatances in the body is too much. So start in very stable, against the wall, sitting on a stair, letting them get control of these movements in a very small micro manner. So any cues? People are like, how do I move? They get in the water and they're used to having gravity, and now you've lessened that. You've introduced buoyancy, and the strategies they've learned to move on land no longer work in the water. A lot of them, the strategies don't work, and it destabilizes them. They've learned to walk on land. It might have taken them a few months to just be able to walk on land, or years. Put them in the water, and a lot of the muscles that they've used to get around on land no longer are serving that purpose in the water, and they're very unstable. So I give a lot of visual demonstrations, tactile demonstrations from the instructor, from either through their shoulders. For a lot of people in the water, if you put tactile cues into the shoulders or down through the pelvis, it helps give a lot of stability and a lot of awareness, and helps recruit the right muscles. For people who have cognitive issues or memory issues, or have a hard time with judgment, I use visual demonstration, laminate cards, and targets, visual targets in the pool. And auditory, certainly, music for relaxation and timing. I had this one guy who was learning how to walk in the pool. I think I have a little video of him, but he could not get the steps. He could not get the rhythm of the steps. He had a hard time breaking up some ataxia, and moving from a unilateral to contralateral. And after I think the third session, he was like, you know what this needs? It needs John Sousa marching music. And this was something that he could relate to. And as soon as I got it on my iPhone and started playing it in the poolside, everything clicked for him. I had something similar with a little girl who had CP, and she was working on trying to come into the midline to be able to roll over. And every time she would start getting into midline, she'd go into a Moro posture and couldn't complete it. She just couldn't do it. And one day the lifeguard's walking by, and she's laying on her back, and I'm getting ready to do this with her. And she goes, hey, lifeguard. She goes, can you put on some Mariah Carey? And he looked at her, he's like, why? Yes, I can. And as soon as we got Mariah Carey on, she was just like into it, and she's got this little beat going in her, and boom, here comes the roll. And then she was able to, she felt it, she did it, we kept practicing it. And it was something she had worked on for like 8 months, 6 to 8 months. And finally, just with the music, and the timing, she was able to get it down and practice, and that transferred immediately onto land, being able to roll over and change positions, and it was very effective. If during any of the stabilization exercises that you do in this level 1, if you start seeing compensations happening in the water, keep giving, stop the exercise, and then figure out the type of tactile cue that the individual needs in the water. It might be a pulsing, it might be a stroking movement, it could be bringing awareness to another muscle. You might want to be tapping another muscle body to get them to activate it, to stabilize. So you want to inhibit or facilitate the correct kinesthetic response. If they're trying to lift the leg and the whole body, I call it crumpling to that side, the weakness of the hip flexors and the stabilization, the ability to strengthen on the standing leg, and pull the other leg up. You'll see this in some videos. You'll see me do the correcting in the water before they ever do it on land. So you can work, this is somebody with a newly acquired neuro condition, and you don't want them to start using too many compensatory patterns that are going to cause over time maybe a contraction. So this is a seated exercise, just showing this woman, she's in a couple of the videos. She has EDS, and she's post-stroke by, I think, 6 years. She's doing pretty well. And I'm just showing at the beginning how you can use the wall just for subtle shifts. This is a little more advanced than some people might need, but you'll see some other ones. Let's get this going. Okay, we're gonna work on back stabilization, some pelvic floor, multifidus, erectus, some hip stabilization, transverse abdominis. What else? There's all the stabilizers. I'm going to start first in the easiest position and then progress it to more difficult. Okay, I'm going to start with the arms up. Good. And I'm going to ask her to first do a march with her right leg, lift it up, and then back down, up and down. Good? Okay. Yeah. Now I'm going to let go of the leg that I'm stabilizing because she's doing well. I'm going to allow her to do 4-second marching. 1, 2, 3, 4. 1, 2, 3, 4. Okay. Doing very well. And the leg that is not being lifted, I want the person to think of it telescoping and pushing down into the pool bottom. Pushing down on the foot that's on the floor as the other one comes up. And she's doing real well. Some people will start to rotate in the torso or lean to one side. And this is when I'll come in and do some corrective cueing. We're gonna make it harder now by having the arms at the surface of the water and continue with the marching. Good. And I'm starting to see a little bit of weakness in the back. Right around up in here in this area. So I'm going to give her a little cueing. I'm going to stabilize. Stabilize right there. Continue. Is this a little easier?
Yes, I feel more stable.
She feels more stable. My hand is on the erector spinae, right above the thoracolumbar juncture. Good. We're going to make this a little more difficult. I'm going to remove my hands, and her arms are going to go underwater. Continue the right about there.
Okay.
Now I'm going to ask her to continue marching. Really think of pushing your weight through the foot that's on the pool bottom.
This is a lot more difficult.
The degree of difficulty just went way up. Good. Now I'm going to offer some stability at the waist, and I want you to bring the right leg and extend the foot out. Very challenging. Breathe. Okay. Now I want you same leg. Weight down through the left. So we should keep it down. Right leg, lift and extend. Good. And bring it down. Do the same leg. Good. Breathe. Don't forget to breathe. And I'm going to give her a little more stabilization. I want you to think of heavy weight down onto your shoulders, pushing you down. Think of your butt going down to the earth, the leg going down into the earth, breathing air all the way down into the lower abdominal, down to the pelvic floor if you can. So think of bringing air all the way down. And as you exhale, good. And then extend the leg. Good. And bring it in. Is that a little easier?
Yes.
Yeah. So the breath very much assists this activity. So I'm gonna have you try that on your own.
With my other leg.
With the left leg. Think of pushing the weight down through the right, weight down through the buttocks as you breathe in. Allow the pelvic floor to expand. Bring the air all the way down, and as you exhale, extend the leg and contract lower abdominals, and then bring it back in. And as you exhale again, allow the weight to come down.
Good. Thank you.
Mhm. Okay. Now, I'm not sure if you can, if you guys can see me. I made it a little bit bigger. When I had her sit on this, I had her sitting on the stair when they have the arms up out of the water. All this extra weight is approximating her onto her ischial tuberosities onto the step. So she's got a lot more tactile input, more mass pushing her down. And it get a lot more difficult once the arms get onto the surface of the water and then below water, because it's challenging her center of buoyancy. Now, I also can use a ball for some of these folks, and I'll put it between their legs. And it has to be a squishy ball. This one's a little big, but I've got all different kinds, sizes, and it's really sticky. So it works nice in the water. I'll put it between the legs, just like on land, so that we can activate her adductors, and as opposed to having her glute medius on and pulling out. So using a ball helps. Also using the ankle weights, but not on the ankles. I put it actually up here on the shoulders, like so. If somebody cannot lift their arms up out of the water, this gives a lot of proprioception right down onto that step. It works well with doing gait in the pool, but works very well sitting on the stair for people who have difficulty just sitting there. Should I make myself bigger, or can you guys see me on the screen big enough? Yes?
Julia, can we take a short break? Let everyone take a break?
Absolutely. Perfect. Okay.
Let's break until 20 after and then come back. And if you want your image bigger, you can go ahead and stop share and it'll be you on the screen. So everyone can see.
Okay. Oh, I should have done that earlier when I was demonstrating some other things. I'm sorry about that. Okay, got it. Well, I will see you all in about 10 minutes, 5-10 minutes.
10 minutes.
Okay, perfect.
You're on mute, just so you know.
Thank you. Anybody have any questions? I was going to show, now that I'm on full screen, I didn't realize that before. These were the containment briefs that I don't know if I was on the screen before, that show how that they open to be able to get into this type. This was the discovery trekking. These were the other containment briefs. These ones are made either by Kiefer or Sprint. And literally you can pour like a huge amount of water into these, and they don't escape. So they've got a really great containment value for liquids and solids. Then when I departed here, I was showing you the ball, and you want something that's very squishy so that it can be held between the legs for stabilization. You can also, with these fitness therapy balls, you can fill them with water, and then they're the same density as the water. You can hold them between your legs when they have water in them, or you can use them for sitting balance. I've got a great big ball. You can do that with those big round balls like that over there. And you can fill them with water, put them on the pool bottom and use them just as you do on land for stabilization. But the beauty of being in the water is it slows the movements down. It really slows reaction times down, which allows for practice and allows people to try to do, give a little bit more encouragement to try cause and effect of reactions with different positions of their extremities and the use of muscles. It slows everything down so you can work on tapping muscles, tightening, having somebody push against you for the retract against your hands and engage their core. I like bringing the big balls like that into the water. That didn't sound right, but the ones filled with water into the water. So using the balls. Another thing that I do use is when somebody's, this is a typical door stop, just that I will use like a wedge. So if I have a client who's sitting on the stair and I'm working on sit to stand or just shifting weight onto the feet, because spasticity is greater when somebody's standing as opposed to sitting. So we want to be able to load an affected leg, an affected side of the body slowly without having the foot go into supination. So I'll put the wedge on the outside of that foot. I'm going to put the screen down like this so you can see. What I'm talking about. So I'll take the wedge, put it underneath the foot, and that will prevent the foot from rolling. And as they come forward in the water, I'll have them put their weight down onto that leg, shifting the weight forward. Actually, I work on coming across. So if we have an affected side, they use the other side. They put their weight onto the leg, bringing the head forward, exhaling, rolling, dropping the shoulders forward, and then getting the weight to here, and then retracting the shoulder blades, inhalation, exhale, and then back. Just this one position goes a long way, and the person can practice it multiple times in the water as opposed to on land. And I'll use the wedge with somebody that's standing at the pool wall. This is the pool wall here, and I have the affected leg. I don't want it to roll in like this, so I'll put the wedge, and then these stay on the pool bottom. They sink and they stay there. And I can work on bringing the center of gravity, the belly button, in line with the great toe, the sternum, the belly button, the great toe, and then shifting the weight back, coming in towards the wall. And they can lean onto the wall if they need to with the arm, and then back, slowly closing the base of support and bringing it back. Eventually you want to be able to move in, putting the non-affected leg in front and being able to stand. It might be all the way out like this and then gradually coming into midline. So shifting, because a lot of people will be people that walk like this, swinging, circumducting the leg around, being able to get that belly button, sternum over the affected leg. That weight shifting. Okay. All right, let me share screen back. Any question? I'll come back to that again. Okay, I shared in the chat room a PDF file that has the progressions 1 through 4. simply written down the ones that we're going through in this PowerPoint. Okay, switching screens. Bring it back up here. Okay, we already saw that slide. Okay, now moving into the isometric core stabilization. Again, you can do this on the stair, or you can do it with the back against the wall. We're still in this level 1, but in rehab, this is where we're working with the people. Let me turn the sound off here. And here's seated with back to the wall and flexion at the ankle, knee and the hip on the leg that's weight bearing. You can have the arm position either palms against the wall like that, but if somebody's shoulders won't allow for that type of slight internal rotation with abduction, then you can have them put the backs of the hands against the wall. And so you're actually kind of pushing back using a little bit more of shoulder retraction. And that really helps. Now I'm doing a draw and maneuver, hold and relax, bringing the belly button slightly towards the wall. I have people breathe down to the pelvic floor at the before we start a lot of these exercises. And now I'm doing clapping in front of the belly button. And the clapping adds a little bit of more water resistance, that helps keep you against the wall. And now I'm doing it with challenging with the crossing the arms, and that's changing the lever position. And I'm moving an extremity. Now it gets very hard if you bring the arms, the wrists out of the water like that. Hands are back against the wall, and I'm doing a toe touch or heel touch to the pool bottom, lifting it up. And then I'll do 1 foot at a time. I'll do plantar flexion and then dorsiflexion. It's important to breathe here. So I'll start with both feet doing plantar flexion, dorsiflexion. Then I'll do opposite. 1 foot, the toes coming up, and the other foot, the heels coming up. That's getting a little more advanced. So each foot doing opposite movements. And then from here, I'm coming across the midline. Again, very slow and controlled. So here I'm sliding the arm across my body. So I'm doing more of coming across. And then I'll bend the elbow, slide the hand down the inside of the opposite arm, across the chest, and back on to the wall, following it with the eyes. And a lot of people won't be able to go that far, even if they make it part way or touch the opposite shoulder. That's a very good, just being able to touch the opposite shoulder or the opposite chest. Okay. I am coming back to here, stop share. Oh, where is it? Okay, here I am. I meant to show you this. These are the weights that I don't put them on the ankle. I put them on the shoulder like so. Now that I'm on full screen, you can see. And these really push the person down onto the stair or onto the bottom of the pool as opposed to putting them on the ankle. And it really gives a lot of proprioceptive input. Try this at your home pool, see what the difference is. I do a lot of tactile cueing on top of the shoulders when I'm doing gait. When I do that, I don't have these on, but these are very helpful for somebody doing sitting and practicing internal rotation, external rotation, little movements on the stairs. Okay, let me go back to the PowerPoint. And here's the tactile cue for transverse abdominis, and the picture on the small box on the right, that is a client who had a more recent CVA, and she had also had a hip replacement. So this is when I asked them to place their hands on both sides, and they can actually feel that the activation of the TA when they're weight shifting in the water. I do use the stairs quite a bit for doing prone stabilization and working on rolling over, working on all fours, learning how to activate and feel the tightness that might be in and releasing of the psoas and the iliopsoas, as well as postural extensors. So let me get this rolling here.
We're looking at multifidus, doing exercises for the multifidi muscle. I'm also going to be giving some cueing for her psoas muscle, transverse abdominis as well. Okay, I'm going to have you put all your weight down through your knee on the left leg and unweight the right. Good. And then weight on the right knee onto the right leg and unweight the left. Oh, good. Nice. Good. Now come back onto just like put your left leg down. Now I want you to extend. I want you all your weight to go through, telescope down through the left knee as you bring the right leg. Just extend the leg as much as only as you're comfortable. Ready? And extend. Good. Now feel this muscle here?
Yeah.
I'm palpating into her into her psoas, iliopsoas, and the transverse abdominis. And I want you to bring this leg, your right leg, bring it back towards the stair. Good. And now I'm going to shift, stabilizing, extend the left leg. Good. And I'm not letting her roll. I'm not letting her do any rolling. Now, just for fun, I'm going to have you with your legs straight. I want you to touch your toe to the pool bottom. Good. And then back up slightly. It's a small range of motion. It's more for stabilizing. Toe down. Good. And up. Good. Excellent. Now I'm going to let go and see how she does on her own. Is that a bit harder?
Yeah.
She says it's harder. Yep. And bring the toe touch and heel up. Good. And down. Now push into my hand. Push, push, push. Keep pushing your weight through the right knee. Right knee. Good. And relax. Excellent.
Yep, so it's a lot of tactile cueing, but I've noticed that clients have had TBIs. They enjoy the variation of the positions in the water. And when I have somebody go prone, she's a little bit tall. Normally I would have, person would have their shoulders over the elbows on the stair. So you don't want them extended. She's a little too extended there. The shoulders are behind the elbows. I would like, preferably, it would be better if she was forward over the elbows, because that takes the slack, that takes the stretch out of the latissimus and some of the other muscles. Now, this is where I call them, where I use the magic with a lot of the neuro clients who are working on strategies for sit to stand. And that's why I showed you the ball earlier and the wedge. And I might even use the weights on the shoulder at the very beginning, just teaching somebody that internal rotation and external rotation. So let this go. So I break it down into small movements. Hi, we're using an extension. All right. Not only does it offer really good tactile cueing, but it also gives the distancing that's required and a little extra support. So I'm going to feel the vibration. I'm creating vibration through the noodle, and this will tell what arm to go and when we're going to start and go. Okay. So from here, I'm going to have you just externally rotate the hands and bring your arms out, and you feel your legs popping up. Whoa. Okay. So to get out of this position, internal rotation into the midline. Good. Think of telescoping your arms out and the thumbs down. You feel your weight on your feet? Mm-hmm. Okay. We're going to unweight now. And I'm going to externally rotate, bring them out, out, out. And you feel your weight shifting. Mm-hmm. Good. Let's bring your head forward like you're blowing as the arms come forward. Feel good control? Mm-hmm. Okay. Good. I'm going to have you move your legs down to the floor of the pool bottom. Good. Now with this one, you're going to be bringing your head right down close to the water and like you're blowing out. So you're going to bring your head forward and blow. Okay. Good. Now let's start at the beginning. Step all the way back like this, and as if your legs are feeling like you're just unweighting a little bit. Right there. Okay, so this is going to bring your feet down to the pool bottom. Thumbs in. Good. Pinkies are kind of up now. Good. Drop your head down, round your shoulders. Exhale, and feel your weight come over your feet. When you feel the pool bottom, is that it? Yep. You feel good? Yep. Excellent. From here, I want you to fire at the knees. Good. We're gonna sit down again, and we're gonna go down slow, and then back. Good. So this time, I would add another piece of equipment for the powering to stand up. But we're going to go back one more time, arms out. Good. Your feet feel like they're popping up. Mm-hmm. Think of your head telescoping up. Good. Now, as you exhale, drop your shoulders forward, arms forward, internal rotation, like you're blowing into the water. And when your weight comes over your feet, fire at the knees. Good. You feel like you want me to push down a little bit still? No. Okay, good. I'm going to remove the floats. I'm going to do it once with a tactile hand cueing. Take your hands. Good. Relax your arms. Good. So if you're here and you feel like you're floating backwards just naturally, to get balance, come forward, drop your round the shoulders forward, drop your head down like you're exhaling. Come forward. I'm dropping your arms way down. Now, when you feel like your weight's on the ball of your foot, I want you to start to push up. And I'm going to externally rotate the hands. Nice. Excellent. Good. All right, good. Mm-hmm. With that one, even if somebody doesn't have good arm movement, if they've got somewhat contracted arms, I still teach this one. I teach of just tightening the pecs, tightening the scalenes, blowing out to come forward, and then trying to relax the pecs, relax the shoulders, just to sit back down on the stair. And I have them use their eye, the positions of their eyes. I'll have them look down at the bottom of the pool, tighten their pecs. if they can squeeze their legs together, or squeeze my hand between their knees, that will also help bring them forward in the water and onto their feet. And then I'll have them relax the tightness of their legs and relax their pecs, and I'll have them look up with their eyes. Just avert the eyes towards the sky and they'll go right back. So anything that does flexion or internal rotation in the water will cause flexion. Anything that is externally rotated, or even external rotators are contracted in the water, that's going to cause extension or going back in the water. So once the individual starts really feeling these fine tuning of contract, relax, of whatever muscles that they have that will work, and you can work them in the sequence, they're going to gain control. And as we mentioned at the beginning, all anybody really wants, what we're trying to help them attain and what people want is control of their body, of their movements, and to go where they want to go. And some people have maladaptively learned how to do that on land, and we don't want to take that away, that some of those movements and spasms are functional on land. So you have to, look to see, you don't want to disrupt something that is working and functional for them on land if it's helping them get around. So you, as a therapist, you want to assess for that. I like using the two different color water noodles. Sometimes I'll take my hair scrunchies. I usually have two different color hair scrunchies, and I'll put that on people's wrists if they have a difficulty discerning right from left or one side from the other. So then I can just say green and pink, or different, whatever color I happen to have, so they can identify one arm or the other. This is doing another seated exercise, proprioception and trunk control with weight shifting. And this is weight shifting in the seated position. And it's learning how to lengthen one side of the body, where you have to inhibit, you've got to inhibit contraction. So let's let it go. We're going to be doing weight shifting, where you can feel the ischial tuberosities one side of the body to the other. At the same time doing eccentric lengthening, because we don't want that buttocks to come up off of the seat. We want to keep it planted down. Okay. All right. I'm going to bring you side to side. We're going to go one side and then the other side. You feel how your butt wants to pop up, like right there. Okay. So for cueing, I can either stabilize with my arm on top of the knees, putting pressures straight down, and I can go from one side to the other. Relax your elbows a little bit. There you go. And you can feel the pool bottom. The pool bottom. Now, if I let go, feel how you want to pop up a little more. Okay. So what I want you to do is, as you're doing this, think of pushing, keeping your tailbone, those bony spots in contact with the stair, so that as you're going across, you're lengthening that part of your body. You feel that? And over here, over a little bit. Yep. Over here, you can feel this side lengthening. So this is eccentric contraction and eccentric contraction. Good. If I want you to continue to do this on your own, it takes a lot of energy. You have to think of weighting your butt down like an anchor as you're doing, keeping the sits bones intact. Can you feel the contraction? Now, if I let go, that's a little harder now. You have to think of putting this foot down. So I'm changing my hand position. Good. And I'm going to come across. Does that help? This tactile cueing? I'm going knee to foot. Good. Keep that leg down. Good. Opposite,
I made it
one
work.
hand's on the knee, one hand's on the foot.
Now I'm gonna do it without touch. Yeah. Excellent, you're doing good. But you have to concentrate. Yeah. Yeah. It takes concentration to keep your ischial tuberosities in contact. It's difficult. Okay, good. Stop.
And I like doing that one with clients who might have like the a Tredelberg gait on the stair before we start doing some of the walking, just to help break up the bring some proprioception to the movement that we're trying to attain. You can also take those weights, the ankle weights, and put them, just drape them like I did over the shoulders, but you can try it on the shoulders at first, but ideally to put them on top of the thigh, just above the knee on the lower thigh. And that gives a lot of tactile input that is very assistive for them. And then move the weights, then you can put them on the ankle at that point, from going from the knee, then above the knee, and then you can actually clip them onto the ankles and have them try it with the ankles. Sometimes I'll leave them on the ankle and then work on that sit to stand from that position as well. Now, this is the woman that is more of a recent CVA. I think this is a longer video, but I'm going to show it. It will show really what I would typically, a real treatment. Like, this is the first time I've ever worked with her. And so I think it's a good thing to show.
Okay, I've got Anne here laying horizontal in the water. And Anne is a stroke survivor, CVA. And we can see the tight musculature here on the right side of her body. As you can see how the rotation is happening here. She's abducting the arm out to get greater stabilization. And I want to work on the gait pattern. This is pre-gait. We did gaits. We're going to show how we're going to progress this. So I'm going to be taking the bottom of the feet. I'm going to have my hand on the planters, on the dorsum of the foot, my other hand. And if you can zoom in on this, I'm going to have my hand on the ball of the foot and the toe. And I'm going to alternate. I'm going to go pull and approximate. Pull, approximate. Pull on one foot, approximate on the other. Okay. I'm going to go head first. And I'm going to push and pull as I step forward, push and pull. And I'm pushing in to the hip joint as I'm pushing. And now I'm pushing. And I'm going to come back towards you, okay? And you can pan out a little bit farther. And I'm going to really simulate walking here. So I'm going to go plantar flexion, dorsiflexion, plantar, dorsi, plantar, dorsi. How's that feel? Good. Yeah, it usually has a very nice sensation. The rocking happens through the body. Good. And we can see how when she's floating, the tightness, you've got a lot of tightness right through here, don't you? Mm-hmm. My hand is on, is at the QL behind her and her erector muscles. And I'm just doing a little bit of vibration to open it up a little bit. Little vibration, little opening, little vibration. Because I want to get some of this natural rhythm. You okay? Mm-hmm. I'm gonna lengthen the right side of her body. I'm gonna open her up, lengthen, 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 and then let it relax. My hand is coming along the ASIS and the lateral border of the pelvis, and my other hand is on her scapula.
Oh, it's wonderful.
And I'm gonna pull back on the scapula and push gently on the pelvis. Opening, opening, opening. Good. Opening, opening, opening. Good. Gentle rocking up and down the spine. This working for her. Each person is different, how the release to loosen them up. Good. And I'm gonna do a couple of pelvic figure eights. And now I'm gonna go the other direction because you can see how she's still pulling in. I'm gonna go down, up and around. And I change direction for every direction I go. I'm gonna change the direction.
You can see how she really bends to the right because everything's very tight on the right, and seeming very stiff when I was going to the left. Now I'm keep trying to open up the right side.
Good, now I'm gonna try the gait again, and without the pelvic support, because we've helped loosen her up a little bit. A lot easier. And we're gonna go forward,
Nope, no.
forward, forward, forward. Think of telescoping your head up. Think of pushing your head straight up as I'm doing this, okay? Okay. Feel that?
Mm-hmm.
Good. Push back against me. Push back. Good. Pull on this leg and push into my hand.
This one push.
Pull. This one you're gonna pull. Pull,
Okay.
pull. Okay, stop. I need the pelvic support in this.
Yeah, and I let this run so
The
you can,
belt floated away, but I'm gonna use this for a moment. She doesn't have that proprioception due to the CBA. So are you getting our whole bodies in here?
Yes.
So when I mean pull, you're gonna stand on this leg, stand, pull up on this one, bend the knee, pull against me. Good, and relax, okay? Now I'm gonna have you pull back on the right. Pull back on this leg. Pull, 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 stand on this leg. Relax, keep breathing. Don't pull so hard that you go off balance.
Okay.
Push your belly button towards the sky. Belly button up. Good, and relax. Okay. So it's more difficult for her to stand on her right. So I'm gonna keep working on the right. I'm gonna give her a surface. If I want her, she was using too much of her adductors. So I'm gonna place my hand on the lateral border of her foot. And as she pushes on there, it's gonna prevent her, inhibit her adductors. Okay, so you're gonna pull back on your left. Good, stand on your right. And stand, Good. Straightening it out a little bit. Good. Pull back on your right. On your left.
Pull back.
So when I mean pull, you're gonna pull against my hand. There's nothing else to pull against, right?
Okay.
Just that. And we're gonna stand on this. Stand and pull. Keep breathing. Good. Now I'm gonna put my hand outside. Keep pulling back. Pull. Stand, stand, stand. Good. And relax. Good.
That's a lot of
I'm gonna
work
do a
for
little
somebody to
pulsing
do.
into the IT band here to help inhibit some of her adductors. And pulsing, pulsing, pulsing. Peroneal muscles. Good. Now we're going to try this again. I'm going to have you stand on this against my hand. Stand and pull up with this foot. Use your toes. Pull up. Good. That looks really nice. Breathe. Pull back. Keep pulling. Up, up, up. Nice. And relax. Excellent. I think that looks a lot better than when you started. Yep. Now we're going to do the other direction. I'm going to have you stand on this foot, on your left, and you're going to pull up with this foot.
Okay.
Bend your right knee, pull up, and you're going to push into my left hand with your left leg. Good. Good. Now, and relax. Good. Stand, push into my hand on this leg. Good. And I'll pull back on this foot, on your right foot. Bend your knee, try to bring your foot up. Little drop foot here, so I'm holding up higher on the foot. Good, and push. That looks beautiful. Okay, and stop. Excellent, man. Okay, now we're gonna go back to doing the gait and see where we're at. Oh, look at the improvement.
Now she's getting dorsiflexion, plantar flexion.
Good.
She's getting
Feels
some
a
ankle
little different, doesn't
strategy.
it?
Yeah.
Yeah,
There we go.
Feels totally different.
feels very different.
Wow.
Good.
Hey, wow. Feels like a mermaid.
Yeah, nice. Now I'm gonna help stand you back up. Relax. Okay, bring your head forward. Good. Feel the cool bottom.
Mhm.
Good. Reach for the railing and then stand up. Good. Nice. Now I'm gonna have you walk across the pool like we did at the beginning
Okay.
and see how you feel.
Okay.
Okay. Heel toe, heel toe. Fire at the knee. Fire at the hip. Oh, that looks nice. Ta-da! Come on, walk back.
That was fun.
Let's do nice alternating arms. Heel toe with your feet. Good. Hey, how's that feel?
Ta-da!
Oh, thank you for giving me the opportunity to work with you today.
Yeah.
Yeah.
Fun.
Mhm.
Okay. I know that was kind of a long thing. I'm going to stop this for just a second here. Okay. Anybody have any questions about that? It was a kind of a long video, but it was a very good representation. When she first came to, I wish I had somewhere in here, I probably have the picture of her walking when she first entered the pool. And it was very unilateral, very stiff, not much ankle flexion at all. And, we need to have a good, active range of motion in the ankle to support the knee movement during a gait, the knee and then the hip. So it was, I was really happy to see her have that kind of improvement from doing that. The next couple of videos, I think I break it down with somebody with a size 10 foot, so you can really see some of the nuances of the hand positioning on the foot. At one point, you saw me do a vibration into her IT band, and it's a pulse into the IT band. Then I move, it goes kind of like that, about that much, and then I go down to the peroneal muscle and I vibrate into the peroneal, and then I let go. And if that's with somebody that has very, very tight adductors, even somebody that with to the extent of scissoring their legs, and that will help override that, and it relaxes and inhibits the adductors and lets everything release. And then you can work a little bit more independently on the joint range of motion at that point. Okay. And feel free anytime during any of these videos, put a little note in the chat if you want me to stop. Let's get rid of that. Or if just take your microphone off and go ahead, unmute, and then ask a question if anything pops up. Okay. So this will be for foot supination, a different way to place the foot into a different position and the whole leg into a different position. This is a supination. So to prevent supination, I'll put my hand hold, as you saw earlier. Oh, I'm sorry. Jeez. This is a supination. So to prevent supination, I'll put my hand hold, as you saw earlier, on the medial portion of the foot, and I'm going to put the foot and the whole leg into internal rotation. This then will have her do eversion. Even my hand comes into the bottom of the foot, and I have her preventing her from doing supinating of the foot. I'll do it on this foot also. If you bring the knee, the hip, everything into internal rotation, and your handhold is on that medial border of the foot, it's going to prevent that supination. You can't roll your foot inside if you wanted to, could you?
No.
If you wanted to do a foot roll, yeah. And this was the client who was she's got EDS, Ehlers-Danlos syndrome, and post CVA 6 years. And she has had surgery on her ankles, and she's had terrible ligament damage in her ankles. And I wanted to get her in the water and show this because it was affecting a lot of her gait. And we know that with CVA, 40 to 60% of clients present with a hyperextension of the knee. And it's very important to have a 5-degree flexion in the midline stance. in order not to cause continued knee and hip damage and to get a more effective, stable gait. So let's go to the next one. This one I'm probably going to fast forward because we saw a lot of it with the other client.
Okay, this one I like to do because it simulates, starts to simulate walking. And they can feel the bilateral movement through their body. And relax your legs. I'm getting you all the way up in the corner so that we have the full length. So I start this one passive. We're going to do one pass passive, then we're going to add passive assist, and then we're going to do it active. So passive on the dorsum of the foot, plantar surface of the foot, and I'm going to alternate. And I'm approximating using that positive righting support right into the bottom of the foot. I'm going to go the other direction now. Push, pull, push, pull, push, pull, push, pull, pull, pull. And I'm going to come back towards you.
I turned the sound off just for a second on the video. I'm with the great toe. A lot of people that have had any kind of spinal cord, central nervous system, they have loss of sensation in the feet. So I do a lot of pushing actually through the foot so they can feel it in their hip. It goes, you keep the knee slightly extended, and they're feeling the movement in their hip, not so much their feet, and then trying to retrain the ball of the foot, the toe, to come down into plantar flexion.
And now I want her, you don't walk around with your arms up in a giant Y. So we're going to change her arm position. Yes, good. And I'm coming back. See the difference? Yeah. There's a big difference that she's feeling in her body. She's starting now to feel that contralateral movement, also in the scapula. Good. And I'm going to relax. Now, I'm going to ask her to become a little bit more active in this. So it's that was a little bit active assisted, but let's see how active she can get with it.
I'm going to move it forward a little bit. Here we go.
Her leg wants to go out. You feel that? Yeah. Now, if I press on the outside of the lateral border of her other foot, I can transfer the foot into abduction out to the side. If I want to bring it back in, I'm going to be push with your toe, push with your toe, push, push, push. And now I have this internal rotation. Good. And relax. I switch hands. And I'm going to have her push with her toe. And I'm on the instep of the foot. And she's going into internal rotation. And I'm pulling back the whole time on the dorsum of the opposite foot. Good. Now I'm going to go into external rotation. Good. And here I'm working with the primitive reflexes of the foot, mainly the Babinski reflex and it's the Babinski positive righting support and a tendon guard reflex that are in the foot. Okay, now if somebody has a wide gait, they're circumducting their foot, or they're leaning onto their assistive walking device and swinging their leg around, Or they're just afraid of falling and they have this really wide gait stance. We want to help the person bring that weight more into midline instead of way out to the side. We want them to feel it midline. When I do that, we can use the Badrigas technique. If she was a very wide gait walker and I want to bring it more into midline, I'm going to have her stand on my hand and she's going to pull up with her left leg. Bend your knee, push your weight into your right leg. Straight knee on your right, bend the knee on the left. Good. Good. Now this is where I correct a lot of patterns and relax. Hold, relax. Now she had a very wide stance and I had her pull up on the right, push onto your left, bend the knee on your right. Sorry, my bad. Bend the knee on your left. Good. And as she starts bending to that direction right now, she's bending to the left. I want to correct that. I'm going to say, don't pull as hard. Good. Pull up still. Push your belly button to the ceiling. Good. Keep pulling up with your left leg. Hold it, breathe, and relax. Good. If the client starts, as they pull up and they don't have the strength in the hip flexors, they're going to start pulling to the side. Don't let that happen. Allow them time to keep the hips level at the surface and work with your hand holds on their legs, on their feet, so they can feel the right chain. It's a big difference, is it, if I move my hands on the bottom of your foot? Yeah, okay. So right now, we're gonna do internal, external rotation with the feet. I'm gonna give her a cue, bring your heels together, good. Keep your heels together, push your toes out into my hands. Push out, we have external rotation, good, with resistance. My hand comes on the instep. Bring the toes together and drop the heels out. Heels out to the sides. Good, internal rotation. I know that's difficult for her. Good. Now I'm going to bring heels together again. Good. Now bring the toes together, heels out. Oh, good.
These are strong.
I know that's difficult, right?
Isotonic movements.
It's a lot of energy. Good. And relax. Okay. Nice. Now I'm going to do the opposite leg and see what the difference is between the two. I'm placing my hand, positive righting support, right in the bottom of the foot, and Babinski. I'm getting all of it. Okay. So I'm going to push, and I'm going to say, with your right leg, bend your knees. Good. Stand on your left leg, and I'm giving pulsing, little pulsing into the center of her foot with the heel of my hand. Good. Breathe. Don't forget to breathe, and relax. So I'm going to help with a little bit of that external rotation that you saw there. I'm going to change my hand positioning on the foot. Good. Pull back with your toes. Stand on this foot. Good. Now bend your knee on your right leg and hold. Good. And relax. Relax. Good. Now with that wide gait, if we had somebody with a wide gait, I would want to keep bringing from all the way out here. This is where they want to be. If I hold her foot, pull up with your right foot, bend your right knee. Good. Now, if I want to bring her from out to more medial, I'm going to bring the whole thing in and put the leg into internal rotation. Internal rotation and pushing. See how the weight is on all your adductors?
That feels good.
And it feels good to her. Yep. Because I'm preventing that external rotation. relax. We're gonna do that again. So as opposed to having that external rotation, circumducting movement of this leg, if this is how she was walking, like this. Now we're gonna take it from that external position. I'm gonna bring it internal, yeah? And now I'm gonna place my hand along the medial border of the foot and up to the great toe, keeping my hand off the lateral border of the foot. This leg, right leg, I'm gonna have you pull up and now stand on this left leg. Internal rotation, you can feel that all the way up to midline of your body.
Yeah.
Good, good, and relax. I'm gonna place my hand so you can see the difference on the lateral border of the foot. We'll take a break at the end of this video. On the lateral, good. Pull back with your right foot, bend the right knee, and now she doesn't have, this is how her instability. Good, and relax.
Okay, good job hanging in there, you guys. That was a lot to view and not to feel in your own body. Hopefully you were able to, visualize it and see well enough what the effect was on the clients. Does anybody have any questions? Is this helpful? Yeah, okay, good. I think it's 10:19. So, oh yeah, so we came back. Let's take Monica, is it okay to take a 10-minute break here?
Yes, let's go ahead, 10 minutes, come back at the half hour.
Perfect. Okay. Thank you. Hey, welcome back. Hopefully my dog doesn't bark. If he does, I'll let him in and be right back with you. But okay. Anybody have any questions? Because we've been looking at a lot of stuff so far. We're gonna start going vertical now. You've seen a lot of stuff in horizontal, and when I'm working with my clients, I don't keep them in horizontal very long. Maybe like 8 minutes, something right like that, and I'll use very specific pattern to address an issue. I don't do a whole array of stuff with them supine because I'm working on trying to get the right activation and muscle sequencing or stabilizing, and then I want to once they're figuring it out a bit, and then I get them vertical. Okay. Mm-hmm.
Okay,
And I think, yeah, that's what we left off on. Okay. So now we're going vertical. And what I like about doing working in the water is that it allows for the slowing down of movement, and the fear of falling for people who are unstable gets much less. And they're more apt to be able to work in closed chain patterns as opposed to the open chain, which is really good for balance, because static balance and shifting and swaying, all those fine stabilizations and adjustments that need to be made are in the closed chain. And the bottom picture there shows being able to stretch out the gastroc and the soleus muscle and work on getting active. Well, that right there is doing some ankle stretching, calf stretching, and hip flexors. And then up in the top in standing, you can also change the direction of how one stands on a diagonal.
PNF in the pool can be performed in various body positions that are more difficult to perform on land. Use your imagination. In this video, we will demonstrate
So by having her, she looks funny there with a little teeny tiny head, but by standing with your feet in towards the wall and your arm out to the side like that, you're actually getting much greater range of motion at the shoulder than you would if you're standing in the vertical. Because if you're on a diagonal like that and your arm is at the water surface level, and then if you put your feet straight up and down again, your arm, if you kept it in the same position, would be up out of the water by another 25 degrees, 25 degrees. So by changing the angle of how the person stands in the water can greatly affect the range of motion, and their the extremities being supported by buoyancy. You have a buoyancy supported movement, much easier to attain and work on active movements, whereas something like that on land would be very difficult for a lot of our clients. Pulsing, which is just up and down, but holding a very stable body mechanics. And that little arrow is in the wrong place. The arrow should be pointing at the core muscles so that the person isn't, when the knee comes up in flexion and then you pulse the noodle down to the pool bottom, that you're not getting a bowing to that side, not shortening everything and then pushing it down. Because I'm sure if you've ever watched just group aquatic exercise classes, like a water fitness class, and you have people doing this, you see half the people are bringing the shoulder side that's got the noodle on it down toward, everything's leaning in towards the wall. The noodle's coming up and the shoulder's going down and back and forth. And you're getting a lot of lateral flexion of the spine. So somebody who has got lateral stenosis or any kind of impingement, it might feel really good in the water exercising like that, but later on they might have a lot of increased nerve pain. So being able to stabilize the core while you do flexion, extension movements. So this is both level 1 and level 2. And then here, as they're stable, you're going to increase the reps. So with increased stabilization and strength, that stability, you'll increase the reps. And here we have gait cueing for stabilization or activation. First, we're going to see rhythmic stabilization over here on the left. This is the man who really liked the John Sousa marching music.
You're going to send this to the guy who developed this?
Yeah. I want to give him some.
So what he's using there, and you've seen in a couple of the videos, that's called a pecto fin. And it's kind of a new piece of equipment that I've really enjoyed working with clients. But you can do the same movement, even with a kickboard on the surface of the water, or another piece of equipment that I've been using by Danmar. It's called the Dan bar, and that works really well as well. And with the rhythmic stabilization, when the person is walking, my hand placement is going on the, as the leading leg goes forward, the flexion leg, the one that's moving, the one that's up and moving, that my hand is on the front of the pelvis, just above where the leg meets the torso. And the other hand that's on the stance leg, that hand is at the lateral border of the glute attachments in the back. So my hand, I'm going to play it one more time so you can see my hands are shifting with every step. You have to move your hands from one side of the body to the other, and that helps stabilize the pelvis and assists with his gait.
You're gonna send this to the guy to develop?
Yeah. I wanna give you some
Some people need a whole lot of stabilization if they're rolling their hips. People who are like a hemiplegic type gait, you might have to stable quite a bit as they figure out how to the stance on the affected leg as they come around. So also like a diplegic gait, same thing. So let's see, I'm trying to think another one that Parkinsonian gait, you might see that a little bit, where you have to stabilize the pelvis quite a bit more. And then the person in the middle here, I'm asking her to do a self-cueing. She's got very weak extensor muscles. Her glutes are very weak, and her back muscles, multifidi, her erectors, everything is she's been kind of kyphotic for a while. So I'm having her doing self-cueing, and she's placing her hands at the gluteal fold. So her fingers are at the gluteal fold as she steps backwards, so she can actually feel the activation. Anytime you walk backwards in the water, you get back, it's all back extensors. And then on the one on the right, I don't know if that's, oops. I'm using contralateral gait with scapulo-pelvic rhythm. And that I'll use the theratubing. It's also called, maybe it's just called theratubing. They're made specifically for the water. And it's really nice to have a handle on them. And you'll see another video, and you can either use them straight, like as in that picture on the right, or the therapist can actually come across body, like draw it down and across to their across the outside of their opposite thigh, like in an X type pattern. And that really assists the client in getting that scapular rhythm, bringing the arm into midline and the other line. So you're getting a nice broken up scapulo-pelvic rhythm going. And here's also helping somebody go from a unilateral to a contralateral movement. Let's see. Oh, stretch cords. Thank you, Monica. Okay, those are called stretch cords, the tubing. All right, contralateral gait. And so by using the stretch cords, you can get the contralateral gait. You can go from somebody who's doing a uniform gait, not using their arms, or it just might be very unilateral. And you can break up that rhythm of the unilateral and get the scapulo-pelvic contralateral movement going. And we're going to see it here. This lady here, she had 2 brain surgeries. And so she has a TBI. And so it's a short little video, but you can see how I'm using the noodle, and I can choked way up on the noodle, so I can touch her hands as well. So I can tap the hand that we're going forward with. And if she starts going same arm, same leg, contralateral, I can just stop the arms and quickly shift and go the opposite direction. So she starts feeling that contralateral movement. We'll see it one more time.
Watch your back. Good.
And this is what I call it's a neurotactile technique. And the pressure is very specific. It's straight down through the levator for approximation. And the pressure it comes on and off, on, off. So only when, as the person puts the foot down for the strike phase, that's when the pressure gets put onto the levator. So and the opposite leg will come through for the swing phase. And when that when that other leg, the heel goes down for the heel strike, that's when you put the pressure down. I really encourage you guys to practice that one in the pool. Do it together. Try the one with the rhythmic stabilization on the pelvis. Do that one with a partner before you do it with a client. And you can, some people really need a lot of stability to stop the circumducting or the big rolling circular movement in the pelvis, just to inhibit that a bit, so that they can use more ankle knee strategy and getting the weight shifted into midline on the standing leg, getting the center of balance. And then go to doing this, the scapula tapping, and the pressure's on, off, and practice with it. You'll feel when the person that is giving you the tactile input, if they're putting it in the wrong place, it won't feel right to you. But when they get it, as the foot goes down, that pressure, it actually assists the opposite leg in the swing through phase. Very effective. Okay, and then now we're at level 2. All of that was level 1. So level 1 moving to level 2. So level 2, the person is demonstrating stability with weakness. They can find it, but it's weak, and they'll get fatigued very quickly, and they still have pain, but it's localized at this point. And so here we'll disengage from the wall exercises only with stable body mechanics. And some of the people that you saw that have had gait issues, they're disengaging from the wall using equipment and or my full-on, or the therapist's full-on tactile input for cues. And now we'll do walking in all directions, practice breathing and holding positions. During level 1, a lot of time is spent with relaxation, learning how to breathe in the water, bringing breath down from shallow breathing up in the upper by the clavicles down into the lower lobes of the lung, out into the lateral borders of the rib cage, even breathing into the back, drawing the air down to a diaphragmatic breath. And from diaphragmatic breath, you can have them visualize bringing it all the way down to the pelvic floor if they can visualize that. Now, a lot of the things that we've looked at, you say, wow, some of these clients really need to have a lot of cognitive functioning to figure out particularly some of the Badraga's instructions. But when you become very proficient in your tactile cues and where you place your hands on people in the water, and not giving them a lot of confusing hand tactile cues, when you practice them, your clients will have no other direction or means to activate certain muscle groups with the right hand positionings and the right cues. So even though they might not fully encompass the full instruction that you're giving them. That's why we give short commands, strong tactile and visual cues. And then we're moving more from tactile cues in level 2 to verbal cues for correct alignment with movements, giving them more like feeling you can give them verbal cues. Feel like you have a heavy concept. Feel like your foot is filled with lead and you can't move it, or you're lifting your scapulas up, and then you're going to let them tuck them down into your jeans pocket, into your back pocket. So you're using cues like that, lifting the crown of the head up. And then the range of motion exercises now are getting greater than 90 degrees. With level 1, they were about 30 degrees. Now we're going 90 degrees and greater as they're stable, only with stability. And then the exercises, you want them to go in all planes of movements, and we're starting to utilize PNF principles, PNF patterns for balance and strengthening. And you can use, when you're in vertical, you can use a clock configuration. They even have a nice clock that you can put on the pool floor, or poly spots, or different things you can use as a target for the foot to reach out in different directions. So they've got a visual cue. And then you can start adding turbulence and alter somebody's body shape and go from a broad stance to a narrow stance to a staggered stance to arms out to arms in. And then those rhythmic stabilizations, contract, hold, and relax. I'll do pulsing with minimum buoyancy, assistive and resistive equipment, introducing turbulence, introduce aerobic exercise, adhering to joint protection protocols. And the repetitions have now gone from those 3 to 5 repetitions with level 1 up to 5 to 15 repetitions. And the session time has now increased as they are not experiencing pain. There should never be pain with the aquatic program. If you're having pain, something's not going right. Stop what you're doing, reassess, and go to pain-free protocol, pain-free positions. And we're going to work on weight shifting and sidestepping, and weight shifting with external, internal, upper extremities, and a breath to assist with the movements, moving it into and out of the midline. So here I'm going to show, I'm not sure which one of these is the video. This one.
We're going to do weight shifting. All right. And I'm going to ask the client, I'm going to externally rotate her arm, bring it to the side, soften your knees, relax your knees. Good. We're going to externally rotate and then internally rotate into the midline. Do you feel your weight shift to your left? Externally rotate back to the center. Internally rotate, crossing the midline. Externally rotate and open. Good. Now I'm going to take this, I'm going to push it down, underwater. Good. Lean on it. You feel your weight on your right leg? Good. And now we're going to bring it into the middle and up. So we're going to push it out, down, bend your knee, let your knee bend a little bit, and return your weight. We're going to do this to the left. We're going to go out, push it down as much as you can. Good. And recover back in. Good. We're going to go external out, push it down. The weight's hard and on your leg. Good. And pull it back in. Excellent. I'm going to do side stepping now. And we're going to walk about 4 steps to your right. We're going to go external rotate, step it out and in. Step it out and in. Step it out and in. And we're going to go back to your left. External, step it out, in, out. We bring this one in. Good. Step it out, push it down, and then that takes you off balance a little bit. So we're going to go out, down, and in. So we're trying to get that softness and step and the softness in your body for recovery. Okay, so if you might fall. Okay, good. Thank you.
So it's like practicing like a stepping out of the midline, like a side lunge a little bit to help with balance. I think the normal lateral sway, from a static stance, I think it's only, I can't remember if it's 12 or 16 degrees. I think it's 16 degrees. It's like, is what is normal. And a lot of people, you move them just slightly out of that and they lose their balance. So it's very good to practice the weight shifting, the side stepping, and also standing at the wall, as I showed earlier. Let's see. And
How does that feel?
I feel it.
In a good way? It feels heavy. It feels heavy. Good. It's supposed to. Good. Now, if I'm gonna have you now hang on with the weighted leg at the wall, facing me. Good. So that you keep that leg down. It's just an anchor. Okay. And your other leg, give you a noodle to hang on to. Your other leg, you're gonna step forward, put the foot down. Good. Toe down. Good. And then you're gonna step back with the same leg and bring it back. Heel down. So you're gonna step in front of your foot. So you gotta keep your knee soft on the standing leg. And then back. So your foot is anchored and you're going forward and back to whatever's comfortable. Good.
And this lady had
Now
a
we're
lot
gonna
of
take
hard
it
time following
side.
directions. So she's very visual. She had to watch every move,
Out to the side.
but couldn't
And
listen
back.
to a direction and follow it. She had difficulty with that.
Out to the side. And forward. Good.
And this
Now
helps with
this,
people who tend to lock
You're
their
gonna bring your arms
standing leg,
across the wall as you
because you have
step
to
back.
remind them to keep the knee
So
soft.
it's time, you're gonna go leg back, arm forward. Good. And now leg forward towards the wall and the arm goes back. Good. Leg back, arm forward,
And we're doing opposite
arm
directions.
out, leg forward. Excellent. You can use the wall as a target. I can also put numbers of a clock on the pool floor. Sometimes I will use weighted objects and some of the kids' toys. I can have them look down and look for the star or do it color wise so that they can work on doing a clock in different directions. A lot of PNF, but stable holding onto the wall. Okay, good. We're gonna have you now, I'm gonna take this whip and we're gonna walk across to the other side. Think of the weighted leg, so you really have to think of lifting that leg and extending it out. And I'm gonna walk across.
And it was her right side that was much more affected. So you can do weighted leg. Another way to help if somebody has an excessive drop foot is to put a swim fin, like a little zoomer fin. It's a short fin on the affected leg that has the dropped foot, because it creates a lot of drag. So they really have to work on firing at the hip, firing at the knee. And once they get the foot up, the fin helps put the foot into a dorsiflexion to help with the drop foot. Okay, and this is to help assist in breaking up an abnormal extension pattern. And let's see this go.
lateral flexion of the ankle, knee, and hip. The starting position is going to be an internal rotation, plantar flexion, inversion, hip and knee extension. And the hand position, because I'm going to give her traction, which is going to facilitate flexion in her body. So let me put all the right juju on. Relax. Not yet, not till I give you a command. Internal rotation, good. And pull in, pull in, pull in, pull in, pull in, pull in, pull in. Good. My hand goes to the dorsum of the foot. Extend, 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 extend back into plantar flexion. Excellent. Pull it in, and I rotate her into external rotation. Good. Extend, push into my fingers, and turn. Excellent. I'm going to stop right there. I'm going to change the position. Now I'm only doing this on this leg. She's had a lot of surgery on this leg. This ankle's not ready for that, but for good balance, we want to work on range of motion of the ankle, the knee, and the hip. And put it internal rotation, plantar flexion. There we go. And I'm gonna give traction and pull in. Pull, pull, pull. Good. My hand goes to the bottom of the foot. Extend. Push into it with your toes all the way down. Good. Pull in. Externally rotating the foot. Good. Push in. Use your toe. Use your toe. Beautiful. That was really good, Amra.
So what that one is doing, because for an extension pattern, you want to isolate joint movement. So there, I'm trying to get hip flexion. So she's going from that internal extended pattern with plantar flexion, knee extension, and hip extension. You want to strengthen external rotation of the hip. That's what that was doing. And ankle dorsiflexion with knee flexion. Other things that are helpful to break up that abnormal extension pattern would be bobbing in the pool, going up and down, bobbing with the knees out. So you're going down into that external rotation of the hip, a flexion of the knee. So you're breaking up the extension. Supine to standing is a good one, because if you're supine, you got to come forward into flexion. You have to bend at the hips, bend at the knees, and go into standing, which is a dorsiflexion. Doing closed chain squats. And another really good one is tall kneeling. Also doing bridging. The bridging is good. Avoid hyperextension of the knee though with the bridging. I'll do bridging with the knee and flexion. Here's a manual contact assist. This is what I do when somebody's doing gait, but I'll first do it at the wall, using the wall as a target, so the person can feel the correct alignment and learn to inhibit the compensation. And then I'll do it with the gait.
Some clients will present with decreased pelvis stability or compensation due to weakness and will require manual contact assistance to prevent the pelvis from rotating during the performance of the pattern. Manual assistance may provide resistance or stability.
Oh, and then here's the bridging. So this one I'm doing upper extremity bridging. I'm just pushing the floats down underwater. It takes a lot of effort of extension muscles. And then this is what I was talking about, being able to put the hips in flexion, knee in flexion, ankles in flexion. And as a therapist, you can place your hands on top of the foot. You can put your hands on top of the ankle, and if you need to, put your other hand behind the knee and bring them forward to help them with their own flexion and extension like that. Now I'm not using my arms, and I'm just doing flexion in towards the stair. And I'm lifting my pelvis up like you would do a bridge on land, but it's different in the water. You should try it if you haven't done it. Really good for a lot of spine rehab, because it's a contract, relax. And I didn't have floats for my legs. Otherwise, I would do this with float underneath my legs, or as the therapist can hold the feet and give some tactile cueing. I happen to be on vacation and just decided to shoot some video. And this is now doing it with stabilizing my upper body and doing it with my legs. Now, usually I've done this with somebody prone on the stair, like you saw at the beginning this morning, with the woman doing this in prone, where I'm stabilizing her pelvis. Then I'll move up to graduating her to being able to do it this way, more active. Okay, we're moving seated exercise progressions for proprioception and trunk control using extremity positions. Now, these are really fun because you can do it individually with somebody, or you can do this in a small group. And I've even done it in a large wellness classes. I used to teach a back hab class down in South Carolina, and I would get 10 people holding hands, doing a lot of these in a circle. And it was really nice because you're actually all supporting each other. I'll show you a little video here in a little bit how I modify a lot of this stuff, because I Chi, as we know, has great applications for working with our neuro clients. And I made a little sensory I Chi video, which I'll show. But here we go.
Ready? Okay. We're working on sitting and we're back stabilization, pelvic stabilization, posture, strengthening and activation, stabilizing. So you're going to sit down onto the noodle. Feet are flat on the floor. Arms are floating at our sides. And we're looking like we're in a chair, a nice cube. And we're going to lift the fingertips out of the water. Good. And then the wrists. Good. Now I'm going to have you put your left hand down in the water. Keep your right hand out. Reach out towards me, but keep your feet flat on the floor and stable. Oh, yeah. Keep breathing. Now you're going to bring your arm out to the side, wherever's comfortable. Keep breathing. Keep your feet down on the pool bottom. Telescope the head up, the tailbone down. This is getting hard.
This is nice because people can mirror, do a mirror exactly what you're doing.
This is a lot of QL stabilization. Lats, palm up, and now bring it out to the side. This is even harder because we're having to get our shoulder stabilizers. Yep, the serratus muscles. Yep. The lats. Keep breathing. Erectus abdominis, and then bring the arm back and put it underwater. Woo! It's hard.
That was a tough workout.
It is a workout. Okay, and we can make the workout. I'm gonna have her reach her left foot forward, put the heel down, with the leg extended. Left leg extended, heel on the pool bottom. Good. We can make it a little easier, lifting both hands out. Is that easier or harder? Oh,
Harder.
it's harder. Good. And we're gonna put the arms down and bring that leg back. Real controlled, because we're having to use lower abdominal muscles. And let's try it on your right leg, my left leg. The heel is down. Now, you're gonna lift the leg up. You really have to think of weighting the opposite leg, the one that's on the pool bottom. It's hard. And breathe, 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 and put it down. Good. There's many variations of this. You can do a asymmetrical move on the upper extremities across the midline and see how you do with that. Try that one. Yep. And then bring it back across the other way. We can integrate using the ball. Yep. There you go. And we're going to start doing, we're going to face each other. Fingertips. And we're going to do side stepping, like a crab. Step to the left. Good. And the other leg in. Step it out. Bring the other leg in. Good. Tricky, huh?
Yes.
Yeah, this is a lot of stabilizing. One more. Good. And we're going to come back to you.
It's a lot of stabilizing
See how it's easier now?
without a
So
lot
we're
of
leading with the
mobility
arm,
of
looking in the direction
the
Good.
spine.
I'm going to externally rotate, look in the direction. Good. Good. So we're learning to push off of the leg that's on the pool bottom. Now we're going to go back the other way. And step it out and in. Look at it, reach, external, internal. External, internal. Good. Hey, you did great. Good.
So
Thank you.
just like with walking, for neuro strategies for doing like retraining, as the person gets more stable and can try a few more things, you want to add in things like turns or stop starts, add in unpredictability, balancing an object. You can split their tasks and they're between task and attention. So they have to do two things at the same time. Distractions, obstacle courses are really good. Things to step over, things to go around. And you can challenge trunk stabilization muscles with turbulence and resistance. And everything that you can do as the person is getting more stability, and because we need to add that variability in order to get the carryover and get neuroplasticity. So we try things in seated, standing, kneeling. I think this was in the
open chain isokinetic. Hand placement is on the lateral border for abduction, medial border of the leg for adduction.
Yeah, I think that was in the spasticity course, so anything like that we'll skip. So postural extension, this is stepping backwards, walking backwards.
On the inside there. Okay, we're gonna ask the client to hold the noodle down like a U, like a swing. And what it does is it activates the latissimus dorsi. We get a little bit of QL because we're gonna do weight shifting. Definitely gonna get QL. We're getting rhomboids and multifidite. So I'm gonna have her shift weight from one side to the other and not blocking the knees, keeping the knees unlocked, but just shifting the weight. Good. Nice. All right, now we're gonna walk backwards and we're going toe, heel, toe, heel. And this maintains the proper musculature. We're getting the glute medius muscles activating. And now we're gonna walk forward. But as you come forward, I want you to really think of pushing the noodle down as you activate your lower abdominals, lifting the knee up. Good. Heel toe, heel toe. And just try to go real smooth. Good. That's tricky. There you go. Use the lower abdominals, shifting the weight. Good.
We've taken her
How does that feel?
wide arms
Feels
out
good?
of the
Take a few
equation.
steps back. Pull the noodle down. Breathe, breathe, breathe. Toe, heel, toe, heel. Good. And change direction quickly. Come forward. It's a little harder to change, do a rapid change of direction. And go backwards. Oh, good. So we're going to do quick reversals and forward. Good. Now I'm going to make it harder. Keep going forward and step backwards. Toe, heel, toe, heel, toe, heel. Good. Nice breathe. Okay, thank you.
Kneeling is pure postural extension.
Just below the knees, upper shin. Ask them to place their hands on the deck, on the pool deck. We're going to go in a progression. So by having the hands on the pool deck, it assists with the stability. Marie, now you're going to push your knees towards the pool bottom. Excellent. Engage your abdominal muscles. You feel that?
Yes.
Good. Nice. Now, to make it a little bit more difficult, we're going to place the hands on the bar in the pool, in the water. And this activates more of the transverse abdominis. Use your glutes. Push the knees towards the pool bottom as you engage your glutes. And breathe. Good. Now, if you feel like you're stable and in control, you're going to let go of the wall and you're going to draw your elbows back, keeping your arms under the water. Good. Draw your elbows back and push the water forward so you're traveling. Excellent. Great back extension, extensor muscles, core control, strengthening. Excellent.
Now, she was swearing to me that she would never ever be able to do that. And so she came a long way. She was able to do that after just a few sessions. And then core strengthening with balance. You can use a small soft ball. You can hold it between the thighs, the knees, to will engage the iliopsoas, TA, and the hip adductors. You can sit on a kickboard and do single leg extensions for pelvic stability, hamstring, and lengthening the hamstrings with extension. So now we're adding a bit of variety to this. And oh, our good friend, the planks. Yep, planks on the wall. And then, which is the most stable. And then use different water depths different water depths, and that affects the angle of the plank. So try with a very almost a vertical plank, just barely leaning in, and then go to a more of a prone plank. Then also with your legs, you can go from a wide base of support to a narrow base of support. So you can see in the first picture, it got wide legs. Then with the noodles, the one on the noodle, now we've got challenging stability by doing it on a noodle and bringing the legs a little closer together. And then I'm at the wall and I'm actually bringing one arm across the midline, and that's getting much more advanced. That's kind of up at a level 3 now, 3, 4. And then side planks targets the quadratus lumborum, transverse abdominis, and the oh my God, I'm having a brain fart, iliotibial. Okay. Balance and core in groups. And now we're addressing some of the psychosocial aspects of people with chronic pain and neurologic mobility issues. And as I mentioned earlier, I've been doing lately a lot of group classes, or including people into my community programs that have more advanced Parkinson's and CVA, post-CVA, some mild hemiplegia, Guillain-Barré, and being able to have them in my Chi class, and we'll assist them by holding hands and doing a lot of the exercises in a large group, holding hands. So we're actually supporting the people that need the help. And you get laughter, fun, you have physical support, you've got group support, community support, you have contact with another person, or you can do it with using equipment between individuals. And it has several degrees of difficulty for each person, for each exercise, so everyone can participate safely. And here you don't see anybody holding hands, but typically it's done holding hands. Okay. And okay, I'm going to go through just a little bit more here, and then we'll take a quick 5-minute break. Level 3, now the person is demonstrating stability with the 10 reps, and they're having intermittent discomfort. And we're doing warm-up walking, specific rehab strengthening, increasing the resistance and or turbulence while maintaining postural integrity and correct biomechanics. The range of motion is greater than 90 degrees. The reps of now 15 to 30, depending on the day and the particular exercise. And we're going to want to go for an aerobic intensity during their time for 15 to 20 minutes. So now we're trying to get some conditioning. So now we're going looking for overall, fitness and endurance. And a lot of the research that has come out for neurologic conditions, particularly stroke or people with spasticity, shows that what's improving the most is their balance and activation of the gastric soleus muscles, increased cardiorespiratory values. There are some other ones. Endurance and less fatigue, and showing improved assistance with transfers, with 1 and 2 person transfers. People are able to stabilize more, hold themselves better. You're seeing a lot more isometric strengthening. So I'll keep going here. So then we also add in some modified swimming techniques, but no out of the water recovery. So this is when I start getting people to learning to do modified backstrokes, maybe using a snorkel. If they're not into doing swimming, but they want to participate in the I Chi classes, the water walking classes, back hab, water yoga, all of these are great transitions.
Make sure that the pelvis and feet face forward as the body moves along the diagonal. Repeat moving backwards, this time crossing behind the leading leg along the diagonal. To increase resistance or add variety during PNF gait training, there are many options. Holding a tray in front of or behind the body along the diagonal will increase the frontal surface area. Manual contact assistance can create isometric or isotonic muscle contractions. The aquatic practitioner can provide assistance with streamlined turbulence. Or the aquatic practitioner can provide resistance by creating turbulence. Rhythmic stabilization improves trunk stability during water walking. Using a tray, move it in circles during water walking while maintaining upright posture. Reciprocal.
Okay, you guys okay with taking like a 5-minute break and shake your body a little bit, and then before we come back, and you all right with that? Too far. Okay, and most important, where we want to be this whole time, we want to be keeping in mind the saliency of what we're doing here, and make all of our activities are leading towards ADL specific exercises. And the image of the woman on the left, we're working on a functional reach. So being able to use the lunging, the stepping into and out of the midline. From the very beginning, we would have been working at the wall, which I showed this morning, of shifting the weight from a wide stance over to the affected leg, into midline, and then going into a staggered stance, shifting the leg into midline, up to working with doing those clocks on the side of the wall, holding the wall, and then going opposite arm, opposite leg. And it's all leading up so that we can work on stabilizing and holding a position without falling, and working into how to execute a functional reach. So bringing everything like, full circle. Everything's been broken down into small components to learn how to stabilize and figure out the right muscles in order to get everything specific. And then you increase endurance only with the quality of movement. Now, the gal that's trying to do the functional reach there, she wasn't doing a very good job, so we didn't continue with the exercise. We had to go back and work on a few other components so that she would be stable on land and not hurt her back and her hip. And okay. So level 3 now, we're doing improving posture, proper and frequent cues. So while they're trying to execute the functional maneuvers, and just keep coming back to giving still the cues of about like retracting the chin, bringing the chin back, or whatever is falling out of alignment, out of the posture, to execute the maneuvers so that they don't go back to compensatory patterns or develop them. Simulate different ADL activities, either in the water, out of the water, moving now from water out of the water, lifting things from underwater, out of the water, putting them on the pool deck, start working on like showing if you had to carry plates at home, if that's one of the functional things somebody wants to be able to do, is empty the dishwasher, or walk across the room with a tray. Simulate these activities in the pool, bring that stuff into the water, find out what it is that they need to be safe and stable, and what will be helpful in their living situation. Even if it's, if they're not, even if they have a full-time live-in assistant, or their spouse is helping them, find out what it is that will be the most what's the most beneficial activity, and whether it's stabilizing for a transfer or lifting up off of the toilet, sit to stand, things of that nature. So breaking them down, work on the kinematic sequencing, and then having those carry over into land-based activities. This is doing isotonic stabilization with aquabands, seated dynamic stability challenge. And again, this is looking a lot now like the land, isn't it? So we're bringing in, being able to do the weight shifting, lunging forward, back stabilization exercises. Now, as opposed to walking backwards in the water or holding a water noodle down below your buttocks, now we're adding the resistive bands. Now I'm trying to do this one as like as a functional exercise for being able to lift the feet up off of the floor, stabilizing on the stair. And then I think I'm either going to do some asymmetrical movements. Now we're adding a little bit of PNF to the exercises. I'm gonna fast forward. Up, challenging with upper body, changing the position upper body, and doing a D2 lower extremity pattern. And this is good for somebody who just wants to be able to seated balance at home on a chair, and all of this helps with being able to shift weight in the chair, get out of a chair, help with transfers, getting into a car. gonna go, da, 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 da. Now I'm doing D1 legs, clapping. You saw that earlier. Okay. Oh, that band that I was using in there.
Doing those seated activities in?
I'm sorry, what?
What depths do you recommend doing those seated activities in?
You know, if the bust is out of the water, so if you've got the scapulas out of the water, that adds enough weight to keep you down on the pool step. Now, at the beginning, somebody would definitely not be able to do that because they don't have the stability or the core strength to not pop up out, off the step. So that's why learning all of those head and arm stabilizations, building up that core stability to get to that point. That's why that's now at a level 3. It gets harder if you go above nipple depth, and it gets easier if you go down to waist depth, just above the belly button.
Okay.
Yeah, but I like doing those seated PNF stuff. They're very hard to do. I don't know if you saw me just trying to breathe.
Yes, right.
And I've got hardware in my back, and I had a lot of ataxia 10 years ago, 8 years ago. I was using double canes, and so I've kind of been down this road, and I'm speaking from experience of telling you when I first got in the water, I could not figure out how to walk in the water, how to move. My whole datum points, rotate, everything was off, and it was terrifying. And I was kind of like, kind of relearning. Basically, that's what you're doing. You're relearning a lot of this stuff and how to activate, learn how to reactivate stuff. So that band that I was using, it's made by Rider Band. And I know ATRI was selling them. I don't know if you can see me in the image or not, but when I go back to full screen, I'll show it to you. But I really like using those, that band, because it gives you ways to figure out how to increase the resistance very easily. So
that's by Hydrorider, and if you show it to them, it has pockets where you can adjust. You could put your arms in different slots, your legs in different slots, or fold the band back on itself. So it is very nice.
I love that. And when I go back to full screen, I'll show you that and a couple other things. I'm going to let this video here play for a second. You can hear my dog barking at the door. Let me get him.
The buoyant cuffs assist the movement when moved towards the surface of the water. The cuffs resist the movement when moved towards the bottom of the pool. In PNF D1 lower extremity, the cuffs assist with the flexion phase and resist in the extension phase. Use the cuffs appropriately. Remember, let the eyes follow the feet. Performing PNF in the deep water is an ultimate challenge. Wearing a flotation vest will provide buoyancy and verticality. Wearing an ankle weight on the unmoving leg offers stability. Holding on to buoyant handbars will also provide stability. The pattern is the same: extension, flexion. Symmetrical PNF in the deep is another option for higher level clients. Hip extension, bilateral hip flexion. Plantar flexion of the feet, dorsiflexion of the feet. This asymmetrical pattern shows one leg performing PNF D2 extension, while the other leg performs PNF D1 extension.
Yeah, I'll even start those with people. I'll be in the deep water floating with them with the aqua jogger on, and just to help stabilize them so they can feel what it feels like. Because now you have got to recruit a lot of muscles to stabilize to do stuff in free floating in deep water like that. Oh, now we're at level 4. So this is, you probably won't have people in rehab, certainly not, that have reached level 4. But, well, maybe you will, just it depends. But this is more people that are going into their wellness programs, fitness classes, and the ultimate goal is to be able to get people to this level 4 stability with no discomfort. And the repetitions now are greater than 40. You're going to get to a target rate and maintain for a minimum of 20 minutes. And you can even do like HIIT training, anaerobic interval training and cool down and stretching. I'm going to go now to stop screen share. Hey, do you see me? I think I'm live.
You are.
Okay, great. So this is that band. It's called by Hydro Rider. Yep. And these are the pockets that she was talking about that you can put your arms in like this. These are really nice. And you can go each one has a different pocket. And you can see by the numbers the level of how much more resistance it is as you go up. So I really like these because you can anchor these onto the side. If you're holding them way down low, it's you have less resistance. If you choke up on it, make it shorter, it's got even more resistance. Another thing which I do not hesitate to use with people that have weak arms, and some people when they first come, they might have subluxation can happen in their arms, and that's when I'll use a kickboard, and I'll keep the kickboard down like this in the water just to have them depressed down so that I don't want their arms coming up. So I use the kickboard like a tray to walk around in the water. But I will use wave webs with people that have weak upper extremities when they need that, or they've got weak lower extremities. Sorry, I got it in reverse. Weak lower extremities, and we want to maximize the effort that they're doing with their upper extremities. So people who are learning to get around and doing more fitness type programs, going in from level like level 2 to level 3, and the only thing that's slowing them down is that they've got very weak legs, or they due to a neurological condition, they've got some semi-paresis. And why not give them the mechanical advantage of using wave webs and or zoomer fins to give the mechanical advantage so they can have a greater level of fitness and independence. I'm going to read off a little bit here of some research because I realized I didn't touch on it. So some of the research that I found on Parkinson's is, let's see, that the research shows that it was, there's a decrease of postural sway in comparison with the control groups and an increase in quad strength. And then with MS and Guillain-Barré, it shows that there was balanced increase somewhat according to the functional reach test, and strength increased somewhat in affected muscles as in the non-affected ones. And let's see. So trying to find pearls of wisdom that are sticking out at me here. So that research was, so they had patients within six months of a CVA were having increased balance compared to doing aquatic therapy for six months post CVA. They're having increased balance as opposed to a control group. And they're having better with longitudinal rotation was reported to be better. There was something about PNF not being that effective. I can't remember what group that was for. For multiple sclerosis for 10 weeks of aquatic therapy, strength increased in all speeds used and mean force values increased 85%. Another research showed greater ease of transfer after a series of hydrotherapy for ALS cases. And we have one for spastic patients here, was immersion in 40-degree water that's Celsius for 20 minutes, measuring with their reflex excitability. There was no change. Elasticity of passive structures changed because of the water temperature, not so much of the type of releases that were being done. No change in stretch reflex, but improvement in gait energy consumptions, reflecting more physiological, normal physiological gait pattern. So there was, let's see, this one was for ALS study, they had standing abnormalities were less and the tone was less. And again, that was for ALS. For stroke, we had prevent soft tissue contractures, preferably by active means. Increase muscle strength. I'm trying to read. All right, well, so that it does, we are having some carryover. And here's another one. There was one regarding I Chi. I Chi was helping clients with post-stroke maintain their balance, which was good. And I can try to find these in posts and put them up too. I couldn't find them until I found a printed out copy. I couldn't find it on my new computer here. So they're on a different file on an old computer.
If you want to send it to us, we can get it to everyone.
Okay, I'll do that. I won't be able to send it to you like right away because it's on another computer.
Okay.
Yeah, that's full. And I only found these printed out copies this morning when I was going crazy going, I know I have this stuff somewhere, but I will. I'll get those for you because they're important. We are just about wrapped it up. Would anybody like to ask any questions? I also have that 6-minute video of sensory I Chi if you'd like to watch that. I'll happily do either or, answer questions, or I can show that if you'd like to see it.
Just have a couple equipment questions.
I'm sorry, you broke up.
I just have a couple equipment questions.
Oh, sure.
I love the idea of the doorstop. So I want to get that to try that. I think that's a great idea. I'm just hoping it stays down.
Yeah, it's just the industrial doorstop. I'm not kidding. And I just kind of picked that up, and it was that like a mother of invention. You know, I had somebody that I was going, how can I address this in the pool? Because, you know, we don't have AFO, and it worked really well. Oh, another thing you can do too, you know, I was showing you the pulsing in supine
Yes,
to inhibit the adductors.
I remember that.
Yeah, a great thing to do. You can do that when somebody's standing. So if they're standing and they're still trying to, you know, pull their knees together, use their adductors,
Right.
and inguinal ligaments are just pulling in everything, you know, they're not activating their glutes. Go ahead in the standing and just pulse into the IT bands and go all the way up to the TFL. Between the TFL and the glute attachments, and you'll see a big difference.
Yeah, I always forget to use that.
I know, yeah. And that works just as well, you know, really good. Uh-huh.
And the gentleman that was walking with the music, what was that bar called?
It's called a pectofin.
Oh, pectofin. That's not what I wrote.
Yeah, pecto, PECTO, pectofin. And he sent that to me just as a trial piece, and now I think, and it was a prototype, and now he's making them. So, but you know, they've got those paddles that are out there.
Yep.
You know, like those paddles. I was wondering if you can take a water noodle, you know, that have the holes in them, and just use like a 20-inch piece, and then put those little paddles stick
Yeah, that's true.
because the paddles actually added a whole lot. When the blades are down like this, you can actually slide it across the surface, and the surface tension really holds it, and
Right.
and it allows you to lean on it a little bit. And then if you turn the fins this way and push and pull, then you get all kinds of resistance.
Right. Yeah, that's a good idea too.
Mm-hmm.
And then the ball that you filled with water, I had seen that in a video a long time ago. And is it a squishy ball or is it a regular therapy ball?
Oh, it's
I mean, they're
regular.
both therapy balls, but one's squishy and one's that firmer material.
Yeah, it's the big physio ball like this.
Okay, that's what I have.
You pull this out, and then you take a hose and you just hold it up to it.
Okay.
And you let it fill with the water. And it sits on the bottom of the pool, and it's great because people who, you know, a lot of neuro clients, you wouldn't think of getting them like this on land, doing a lot of these exercises right at first, especially if they're really challenged or they have ataxia or hemiplegia. This is scary for them. You know, it's very unstable, but they can practice it in the water when it's filled with water, because the water is giving buoyancy support. They can work on bringing the arms forward,
Right.
coming forward onto their feet, trying the palms up and then opening just a little bit, and they can feel the movement going back. This is a really nice transition, learning it first on the stair, then on the ball, and then just being able to stand.
Okay, perfect. Thank you.
Yeah, because I used to bring those PVC wheelchairs and have people practice sit to stand in various depth. I would wheel them down the pool ramp, and they could practice sit to stand from this depth all the way up to where now they're almost doing it, and then they can do it at home.
Right. Okay, thanks.
Yep. Any other questions? I know I haven't taught there to see you guys in a long time. I miss y'all. I see Linda, a couple of people, I recognize your names.
Julia,
Yeah.
so this isn't really related to what you talked to today, but it's related more to you. And you said about your ataxia. Do you have any wisdoms of perils of wisdom, I should say, on treating ataxia in the pool? Like, what did you do to overcome your ataxia? We have somebody who has severe ataxia, and we're just running out of ideas.
Right. And were they bouncing? They're bouncing a lot.
Oh yeah.
Yep, having a hard time feeling like they're being a drunkard walking across the pool.
Yep.
Yeah. I wrote some stuff down here. Well, for me, I had to slow everything down. I really did. I had to slow everything down and then just work at the wall and with my back against the wall and just learning how to shift my weight. And basically a lot of it was weight shifting and marching in place. And it was easier for me to swim than, than it was for me to walk in the water. So I did some swimming, kind of modified swimming at first. And then I started going on the wall and doing closed chain, like monkey. Do you know what a monkey walk is?
Yep.
Yeah, I think I'm here. Yeah. And so I was holding on. Am I muted by any chance?
No, I
No.
can hear you.
So holding on to the wall and then having my feet also on the wall. And I would then go to one side and I would bend one knee, lengthen the other knee, come back into the center, then go the other direction, walk my hands over, and my left knee would bend, my right leg would extend, but my feet stay on the wall.
Okay.
Yeah, my toes are on the wall, and I would go the other direction, and I started doing closed chain stuff. A lot of closed chain stuff helped at first. Then I moved up to doing planks, closed chain planks, at the wall. What have you been trying with this person?
Oh, we've tried
Everything?
we've tried so many things.
Mhm.
We did, like, initially we did weights on his feet. We did weights on his hips. I haven't tried the weights on his shoulders though. I think I might want to try some weights on his shoulders. He's very tall too. Very tall.
What's the ataxia from? Does he?
He had a brain tumor.
Tumor? Yeah. Yeah, mine was something I was going to come out of. We don't know. I had like a contracture of my right leg before the surgery. And then after the surgery, when I came out of surgery, all of a sudden my legs wouldn't do what they wanted them to do. If I wanted to do flexion, like I would go into an extension tone, and like therapists were terrified to work with me of getting their face kicked in because I couldn't control like which way my legs were going to go. And so I was really scared at first. And then I thought, oh, it'll be really nice to get in the water. It still took me 3-4 months to even, maybe it was 5 months to even get to a pool, to get in the water. And it was not what I was expecting. Let me put it that way. And, but mine was an incomplete lesion. It was in my spinal cord. It wasn't from my brain. It wasn't like it wasn't from MS. It wasn't from it wasn't coming from the brainstem, which typically that's where ataxia comes from.
Right.
So I don't know if you can call it true ataxia. It was caused from a lot of swelling in the spinal cord.
And he's getting better, but it's so slow, and it's just, I just want to get him better.
Yeah, it took like 2 years.
Okay. Yeah.
Yeah, it took like 2 years for a lot of that bouncing to, when I would get fatigued, even up until 4 years, when I would get fatigued, you'd start to, you could see my legs starting to do this, or doing this kind of thing. And then at first it was in my whole core, like my whole movement was trying to come from my diaphragm as opposed to other things. Like I couldn't figure out how to, like to walk instead of flexing at the hip. My whole body was kind of like throwing itself into the movement.
Okay, thank you.
Yeah, I'm sorry. I would say the clothes, for me, that's just what I did. And I did not have anybody working with me in the water.
Okay.
I wish I had you. Honestly, that would have been awesome. I don't like to, and I don't want to talk about myself because now I'm trying to help other people. And and getting to be able to shift the weight is a big thing. I wish I knew about standing in the corner of the pool, like right in the corner, and shifting my weight into midline. So if I did fall over, I would just bounce, bang into the wall.
Yeah,
then-
we're going in the corner. He does spend a lot of time under the water.
Yeah,
He goes under, like he thought,
I love
falls
it.
under, loses his balance under the water.
Right.
But
I
he's
felt
good
really
with it.
I felt really good underwater. I don't know if it's the hydrostatic pressure, the evening out of bringing the cranial vault, underwater of the dura,
Yeah,
spinal fluids. I don't know, but it felt it did for me too. It felt really good going underwater, but then having a recovery to make sure you can recover to standing. That's the
right.
big, or rolling over. So that's where the Haloic really comes in. It's invaluable, teaching all of those small refined skills, because it's when you try to do the bigger movements without knowing those small little, roll your shoulders forward, you can come forward, retract and go back. You can move with your eye, with your tongue, forward, back, to the side. All of those finer things is what really helps you gain those fine, with the gross motor skills, but you're using fine motor skills to get gross motor skills. And that's the beauty of working in the water.
Right.
You don't have to do these huge maneuvers, to gain control. And that helps you relax. It helps you focus more. And so, I hope what I showed in the videos, you probably at the beginning were thinking, oh my gosh, this is so simple, some of the things, but that's where you really have to start with
It is, but it makes you, because you forget about that kind of stuff. You forget about starting small and
yeah,
you
people
know,
want to start big, and
yeah. So it just gives you a little reminder to
Mhm.
back up a little bit.
Definitely, back up to where you can tell that they're feeling comfortable and in control, and they're mastering that at that level, and vary it into different activities and positions.
Thank you.
You're welcome. I want to thank everybody for spending their Saturday morning with me. And I wish I was there in person, in your pool. So, Monica, is there anything we need to add?
No, thank you, everybody. So if there are no other questions, that's a wrap for today, and we'll see everybody tomorrow.
Have a great day, everybody.
Thank you, you too.
Thanks so